3D. So we'll be starting with the anterior elbow and little bit of forearm also will be covering, particularly the muscles, some of the muscles and the nerves from elbow which is going. So the three nerves that also will be discussing in the elbow. So you'll be discussing with the anterior elbow, medial, posterior and the lateral. Okay. So let us start. So anteriorly, if we are at the, let me enlarge it further. I hope 3D anatomy model is visible, no? Serious?
Yes, sir, it is visible.
Okay. So, you see in the elbow, if you are putting it in this lower end of the humerus and just at the elbow crease, so what we will find there? We will be finding, let me first remove this one. I'll be putting it again. Let me put this one. So we'll be having a very big pyramid-like muscle, this muscle. So what is this muscle? This muscle is your brachialis muscle. So brachialis muscle is a big pyramid-shaped muscle, almost covering whole of the anterior elbow. And then if we are going on the lateral side, we will be having the brachioradialis, and on the medial side, this is a pronator teres. So three muscles which is covering. Okay, let me start with the, sorry. Let me start with the, the bone first, and then I'll be coming to this. So let me start with that. Then I'll be coming to the muscles. So distal end of the humerus and radius on the lateral side and ulna on the medial side. So here the distal end of the radius is covered with an articular cartilage. And what I told earlier, articular cartilage means it is the low acoustic impedance. So it will be looking hypoechoic. And this side is known as the capitulum and this side is known as trochlea. So capitulum, you see, it is an inverted U-shaped structures or C-shaped structure. And whereas trochlea, it is the depressed, like it's an U-shaped structure. And this part is forming the radiocapitular joint, and this is your ulnotrochlear joint. So this part, so basically we are having the two part of the joint, elbow joint. One part is radiocapitular, another is your ulnotrochlear joint. And distal end of the radius is covered with the your hyaline cartilage. Then the lateral side, we are having an elevation, bony elevation, and this is known as lateral epicondyle. Medial side similarly is having a more projection. This is your medial epicondyle. And here there are two fossa. One is your the where this radial head is going to attach, and another is where the ulnar part is you're getting attached. So there are the two bony depressions for these two part of the joint. Now coming to the posterior part, the ulna is ultimately ending up with the bony projection, which is known as the olecranon process. So olecranon process, again, it will be, the depressed part and the distal part of the posterior surface of the humerus, where it will be articulating. So this is the olecranon process. So now with this, let me first put the important ligament, medial ligament complex, lateral ligament complex. Then I'll be coming to the muscle. So if I'm putting the ligaments parts, let me remove the capsule. So on the lateral side, this ligament complex is known as, let me remove the synovial part as well. So the lateral part, this ligament complex is known as the lateral ligament complex. So what are the components of the lateral ligament complex? So this is one part. So this part, let me draw it. So this part is known as the radial collateral ligament. This ligament is known as the annular ligament. Annular ligament is covering the radial head. So the radial collateral ligament is intermingling with the annular ligament. And this ligament, which is again from the lateral epicondyle going to the ulna, this is known as the lateral ulnar collateral ligament. lateral. So this ligament is your lateral ulnar collateral ligament. So the lateral ligament complex has 3 bands, and we'll be able to see all the 3 bands. So radial collateral ligament, annular ligament, and lateral ulnar collateral ligament, because it is attached one side with the ulna, another side is the lateral epicondyle. So let me clear the drawing, and no, let me. So now come to the medial side. Medial side, same way. There are 3 ligaments, 3 ligament part on the medial ligament complex. So medial ligament complex, this is the anterior band of this. This is posterior band. And this is your the transverse or the horizontal band. So again, the 3 ligament part, anterior and posterior is very easy to visualize. Transverse is little difficult, but still we'll be trying to understand it. So here, where is there is a sublime tubercle. So the sublime tubercle to the medial epicondyle, this is your anterior band. Sublime tubercle to the olecranon, this is your the lateral epicondyle to the olecranon, this is the posterior band. And the horizontal or transverse band is from the sublime tubercle to the olecranon process. This is your the transverse and the horizontal band. So 3 component of the medial ligament complex and 3 component of the lateral ligament complex. Now let me put the muscles. So again, I'm just removing the biceps first, and because the biceps here, only putting it in the elbow, biceps is already tendinous, though it has the 2 band, lateral long head and the short head. So I'm removing that. This is your lacertus fibrosis. I'm again removing that. So I was talking here that this big muscle covering almost whole of the distal radius is your brachialis. And on the lateral side, this muscle is your brachioradialis. Medial side, this muscle is your pronator teres. So anterior elbow, we are having the 3 muscles. Brachialis in the middle, brachioradialis on the lateral side or radial side, and pronator teres on the medial side. Now, if I am putting the other structures over it. So one very important structure is your, what we have discussed, is your the biceps. 2 head of the biceps here is seen. And here we will be able to see the 2 head, and most of the times one will be hypo, another will be hyper. Means they are not exactly parallel, what we can see here. So little bit of, the orientation and the degree. And that is the reason why most of the times one will be looking as a hyperechoic, another will be looking as a hyperechoic. And there is a aponeurotic band which is starting from here. This is known as the lacertus fibrosis. So this also we'll be able to identify, and it will be covering the other structures here. So what important other structures there apart from this biceps tendon? The other important structures is your artery and the nerves. So let me put the artery, let me put the nerves. So here, after the biceps tendon, we are having the artery, that is your brachial artery. And this is the small horizon, the superficial nerves. So let me remove those nerves. So 2 important nerves will be here. One is the in between the biceps, in between the brachialis and the brachioradialis. This nerve is your already divided into 2, is your radial nerve. So radial nerve at the distal end of the humerus will be already divided into 2 branches, superficial and the deep branch, and we'll be tracing both of these nerve till the mid of the forearm. And on the medial side, on the side of the brachial artery is your median nerve. Median nerve on the side, between the brachialis and the pronator teres, it will be lying, and then it will be dipping down between the 2 head of the pronator teres, where it is commonly entrapped, called as pronator teres syndrome. Pathological side, obviously, series will be discussing. I'll be just showing you the course, and it runs between the 2 heads of the pronator teres, and after that, it comes between the uh, superficialis and the profundus, the flexor digitorum profundus and superficialis. I'm coming to those muscles later on. So they are the 2 important nerves from the anterior side. One on the radial side, radial nerve. one on the medial side, that is your median nerve, and one tendon, that is your biceps tendon, and three important muscles, that is your brachialis in the middle, brachioradialis on the lateral side or radial side, and pronator teres on the medial side. So coming to the posterior side, dorsal side, we are having very important muscle covering almost whole of this humerus areas is your triceps muscle. So triceps muscles have three important part of the triceps muscles. So this part is the lateral part, lateral head. This is not the medial. This is a long head, and the medial head will be covering whole deep part. It will be covering whole. If I'm having if I'm cutting it so that you can understand it better, I'm cutting it, and now you see how it is oriented. You see, this is your medial head. So medial head is very big bulk, and it is covering entire humerus is your medial head. The lateral head is this one, and the long head is this one. So superficially, the two part, the lateral and not medial, lateral and long, and deep is your medial. So remember that this medial head is the deeper part, and the superficial part is the lateral part, and medially is your long head. So three head of the triceps in the upper part. Again, let me put the okay. Now, if I'm coming in the forearm, so in the forearm posteriorly, once very small. So forearm dorsal part, normally we divide into superficial and the deep. And in the superficial, we are having very important that dorsally, the most of these muscles are getting attached to the what? To the lateral epicondyle. So in the lateral epicondyle, the tendons which are getting joined together and attached is known as the common extensor tendon. So ventrally, the flexor muscles, they are attached to the medial condyle, common jointly together is known as the common flexor tendon. So common extensor and the common flexor tendon. Common extensor tendon goes dorsally and common flexor tendon goes ventrally. So now we'll be coming individually each of these muscles. First, I'll be talking about the dorsal side, posterior side, and then I'll be coming to the ventral side. So dorsal side, posterior side, and the lateral side I'll be talking together. And the ventral side and the medial side I'll be talking together. Though individually identifying each of these tendon, where it is getting inserted on the lateral epicondyle and the medial epicondyle is very difficult. If I'm going little distally, then we'll be able to identify each of these muscles. So here, first is so when we'll be talking about the wrist, that time we'll be talking a little more detail. So here, this muscle is let me remove the nerves. So this muscle is your brachioradialis. That is one of the superficial muscle. That is not a part of the brachioradialis is actually lateral side. Front also you can see the brachioradialis. In the dorsal side also, the most laterally is your brachioradialis. After that is your extensor carpi radialis longus. These two muscles means brachioradialis and extensor carpi radialis longus. They are not the part of the common extensor tendon. Here on this side, this is your unconeus muscle. That is also not a part of the common extensor tendon. So the superficial layer of the, as I told you, the dorsal side or extensor side, we are having the two layers of the muscle, superficial layer and the deep layer. In the superficial layer, what are all the muscles you can see together? I'm coming one by one. So most radial side or lateral side, your brachioradialis and the extensor carpi radialis longus, these two on the lateral side is not a part of the common extensor tendon. And the most medially or most posteriorly is your unconeus. That is also not a part of the common extensor tendon, but they are the superficial layer of the muscles. So let me remove these muscles. Unconeus, extensor carpi radialis longus, and brachioradialis. Now, these four muscles, what is now here, is your part of the common extensor tendon. So, what are those? From the radial side, if you are going to the medial side or the ulnar side, so extensor carpi radialis brevis, that is one muscle. So then, so extensor carpi radialis brevis is a muscle of the second dorsal compartment. This will be discussing more when we'll be discussing about the wrist. So extensor carpi radialis longus and extensor carpi radialis brevis, they are superficial muscles. Extensor carpi radialis brevis is a part of the common extensor tendon. Extensor carpi radialis longus is not a part of the extensor tendon, but both are, they all are superficial muscles, what we are discussing. So then comes is your extensor digitorum. Extensor digitorum is a very big muscle. So extensor digitorum is the next muscle. So let me remove these muscles, the extensor carpi radialis brevis and extensor digitorum. Then comes is your extensor digiti minimi. That is the fifth compartment muscle, single muscle in the fifth compartment. That is your extensor digiti minimi. That is also a part of the common extensor tendon. So let me remove that. And the last one, which is part of the common extensor tendon, is your extensor carpi ulnaris. Okay, so let us quickly recapitulate what we discussed. So in the dorsum of the hand, most of the muscles, they are getting attached. The four important muscles, they are getting attached as a common extensor tendon inserted at the lateral epicondyle. And what are those muscles? Beyond that, there are three other muscles in the superficial layer. They are not the part of the common extensor tendon. What are those three muscles? And then that means total 7 muscles in the dorsum of the hand, which are in the superficial layer. And deeper layer, other muscles I am coming later on. So for superficial layer, 7 muscles. Out of them, 4 is forming the common extensor tendon. So what are those 7 muscles? Starting from most radially is your, already discussed, is your brachioradialis. After that, extensor carpi radialis longus. They did to one superficial layer, but not the part of the common extensor tendon. After that, extensor carpi radialis brevis. It is a part of common extensor tendon. After that, extensor digitorum. It's also a part of the common extensor tendon. After that, extensor digiti minimi. That is also a part of the common extensor tendon. And last one, which is a part of the common extensor tendon, is extensor carpi ulnaris. After that, anconeus, which is a superficial layer muscle, but not a part of the common extensor tendon. Then comes a deeper layer. So what are the deeper layers in the dorsal surface? So first two layer muscles in the dorsal compartment, that means abductor pollicis longus and the extensor pollicis brevis. So these two muscles, abductor pollicis longus and extensor pollicis brevis, first two compartment muscles, they are deeper layer muscles. Then comes the third muscle, third compartment muscle, that is your extensor carpi radialis longus. And then the another fourth compartment muscle, extensor indicis. So these 4 muscles are in the deeper layer. So what are the deeper layer of the dorsum of the forearm? So deeper layer coming from the radial side to the ulnar side. It starts with the first compartment muscles, 2 muscles, abductor pollicis longus, extensor pollicis brevis. Then the third, the compartment muscle, that is your extensor pollicis longus. And after that, the second muscle of the fourth compartment, that is your extensor indicis. So 4 muscle in the deeper layer. Okay, is it clear to everybody? So 7 layers of 7 muscles was there in the superficial layer, and 4 layers, 4 muscles was there in the deeper layer. So 7 muscles, just again quickly recapitulate. It starts from the brachioradialis, from the lateral to medial, brachioradialis, then extensor carpi radialis longus, then extensor carpi radialis brevis, then your extensor digitorum, then extensor digiti minimi, and extensor carpi ulnaris. Out of this, and anconeus. Out of this, the 4 is a part of the common extensor tendon. They starts from extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. These 4 are the part of the common extensor tendon. 3 which are not part is your brachioradialis, extensor carpi radialis longus, and anconeus. The deeper layer of the muscle, it starts with the first compartment muscle, that is your abductor pollicis longus, extensor pollicis brevis. Fourth compartment muscle, that is your extensor pollicis longus, and the third compartment, sorry, and fourth compartment muscle, extensor indicis. So these 4 muscles are the deeper layer of the dorsum of the forearm. So these are the dorsum or the posterior surface. Now let me come to the the ventral side, and they are forming the common, not all again, but they are forming the ventral side. So first, let me enlarge a little bit. So already you have discussed this muscle was pronator teres. So from the lateral to medial, if you are coming, so again in the forearm, you have to remember that we are having the 3 layers of muscle. Some books says it is 4 layers. Some book it says it is the 3 layer. So superficial layer, intermediate layer, or second layer, and the third layer. Some says fourth layer, but third or fourth layer muscle. Most of them are computed as a deep. So superficial, intermediate, and deep. So superficial, we are having the four muscles. What are those? From the lateral to medial, first is your pronator teres. After that is your flexor carpi radialis. So this muscle is your flexor carpi radialis. After that, this is the palmaris longus. After that is your extensor carpi ulnaris. So these 4 muscles are the first layer muscles. So first layer muscles of the forearm, these are the 4 muscles. Again, let us recapitulate. First layer, and all of them are your part of the common flexor tendon. Common flexor tendon have the 5 tendons. So all 4 of the superficial layers and the extensor digitorum superficialis, that is a second layer muscle or intermediate layer muscle, whatever you say. Some says the second layer muscle is your extensor digitorum, flexor digitorum superficialis. Extensor flexor digitorum profundus is the deeper layer. So middle layer or second layer muscle, that also part of the common flexor tendon. So coming back here, pronator teres from the lateral to medial, pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris. So these are the first layer muscle. Let me remove all those first layer muscles. And after that, second layer muscle or the intermediate layer muscle will be your flexor digitorum superficialis. That is also a part of the flexor digitorum superficialis. You see, there are 2 origin. Let me remove this brachioradialis. You see, there are 2 origin. One origin is your from the radius, and another origin is from the medial epicondyle. So this medial epicondyle, this part is your part of the common flexor tendon. So this is the intermediate layer. After that, the next muscle will be your extensor digitorum profundus. So this one, and another is your flexor digitorum profundus and your flexor pollicis longus. And another muscle is your pronator quadratus here. This is also a deeper layer muscle. So some says these 2 muscles are the third layer muscle and pronator quadratus is your fourth layer muscle. And some says pronator quadratus and these together are the deep layer muscle. So some literature says there are 3 layers of muscle and they are separating they are together, the pronator quadratus and this flexor digitorum profundus and the flexor pollicis longus together as a deeper layer. And some says the flexor pollicis longus and the flexor digitorum profundus are the third layer and pronator quadratus, which is running horizontally, is the fourth layer. So whatever it is, that they are not the part of the common flexor tendon. So common flexor tendon, again, let us quickly recapitulate. From the lateral to medial is your pronator teres, then comes your flexor digitorum, flexor carpi radialis, then comes palmaris longus, then your flexor carpi ulnaris. These are superficial layer, 4 tendons, and deeper next layer is your flexor digitorum superficialis. These 5 together forms the common flexor tendon, which is getting attached in the medial epicondyle. Okay, so these are the muscles around the elbow. Lots of muscles, huh? So you have to remember all those muscles. Now I'll be coming to the ligaments, already have discussed. Now I'll be coming to the nerves. So 3 important nerves, as I mentioned first, is your, let me put the nerves again. So between the brachialis and the brachioradialis, let me put all the muscles also. Brachialis, let me remove these muscles, these nerves. These are very superficial. These are difficult to identify with the ultrasound. I'm removing these nerves. In the 3D anatomy, it is looking like a very, prominent nerve, but actually in reality, these are very small nerves and very difficult to identify. So I'm removing those muscles. So between the brachialis and the brachioradialis, this nerve is the radial nerve. radial nerve will be divided into, let me put the whole of this nerve. Okay, so radial nerve will be divided into superficial and deep. So if I'm making this, fade, then you can see this radial nerve, this is the superficial branch going, and this is entering, turning, and going to the dorsal compartment, that is your deep. And this deep branch continues as a posterior interosseous nerve. So here, where it is turning and going, it is going between the two head of the supinator. Let me remove this muscle, this brachioradialis muscle. They will be having a better idea. So now let me remove this also, extensor carpi radialis longus. So see here, let me remove this also. So this muscle is your supinator muscle. So supinator muscle has two head. Let me remove this also so that you can understand the supinator muscle nicely. So supinator muscle, you see, this is how it is entering. And these supinator muscles have the two heads. You see, one part is getting attached here at the just below in the humerus. Another is your ulna, and it comes in between these two. And where it is entering into these two heads of the supinators, that is known as the arcuate of Frosse. So this is known as the radial tunnel syndrome. And then this nerve, if it is interested, so that will be covered by the Dr. series. And then this nerve continues as a posterior interosseous. So the nerve is your posterior interosseous nerve. So and it innervates most of the dorsal compartment muscles. So we have discussed about the lots of dorsal compartment muscles. So this is the posterior interosseous nerve, which actually innervates most of these dorsal compartment muscles, and it is accompanied by one artery, that is your posterior interosseous artery. You see, this artery is your posterior interosseous artery. So this posterior interosseous artery and posterior interosseous nerve, they run together. Not at the beginning, posterior interosseous artery joins little later. Here the nerve is alone. The artery is joining later on. And when it is coming out of the supinator, that time the artery accompanies it. So we'll be tracing this posterior interosseous nerve, deep branch of the radial nerve, which will be continuous as a posterior interosseous nerve. And then we'll be tracing it up to the forearm, where it will be accompanied by your posterior interosseous artery. So this is the radial nerve. Radial nerve superficial branch also will be tracing. It runs below the brachioradialis muscle. So almost whole of the forearm, it runs below the brachioradialis muscle, and after that it comes into the subcutaneous plate. And here the posterior interosseous nerve, after coming out of this supinator, out of the radial tunnel, it runs below the extensor digitorum muscle. So extensor digitorum muscle is here, and at the wrist, it comes below the extensor indicis muscle, and the last muscle supplied by the posterior interosseous nerve is your extensor indicis muscle. So we'll be tracing this nerve, though it's very fine nerves, and we can identify it by identifying the posterior interosseous artery. Initial part we will be able to identify easily, but distal part is very difficult unless you are identifying the posterior interosseous artery. Okay, now come to the median nerve. Again, all this pathological part will be covered nicely by Dr. Series. So the median nerve, again, median nerve initially runs between the brachialis and the pronator teres. After that, median nerve enters between the two head of the pronator teres. Let me show you the pronator teres. So this is the pronator teres. And if I am going into the pronator teres, you see there are two heads of the pronator teres. One is deeper part. Deeper part is basically a very small part. Superficial part is the bulky part. So radial nerve enters here between the two head of the pronator teres, and that is one of the area where it is getting entrapped, also known as pronator teres syndrome. So median nerve can be getting entrapped there. And also median nerve, when it at the two heads of the pronator teres syndrome, pronator teres muscle, there is one nerve which is known as the anterior interosseous nerve. So anterior interosseous nerves, after it comes, it comes very close to your flexor, the pollicis longus muscle. The deeper layer of the muscle, you remember, the flexor digitorum profundus and flexor pollicis longus. So in between this runs the posterior anterior interosseous nerve. So like posterior interosseous nerve is accompanied by the posterior interosseous artery, anterior interosseous nerve is also accompanied by the anterior interosseous artery. So again, these are very fine nerve, difficult to identify, but still, if you are able to identify the anterior interosseous artery, you will be able to identify the nerve very nicely. So this also will be tracing it till, so main median nerve also will be tracing. Main median nerve tracing is very easy because it's a very big nerve, but anterior interosseous nerve is a fine nerve which is little difficult to trace, but we'll be seeing it by with the help of the anterior interosseous artery. Then comes your radial nerve. Radial nerve in a cubital tunnel, we'll be identifying it at the cubital tunnel. Cubital tunnel syndrome is one of the common nerve intermittent syndrome. So we'll be showing it. And after that, it comes between the two head of the, this is your flexor carpi ulnaris. So it comes flexor carpi ulnaris. And if you are tracing it below, so it will be accompanied by the radial artery, ulnar artery later on, and it will be entering into the Goins canal. So this much what we'll be discussing. Okay, now any questions, if you can ask me quick question, then I'll be taking little break to set up my cameras, and then I'll be starting the.
Sir, can you explain Alan alone again, sir?
Pardon? Ulnar nerve after the cubital tunnel, it will be going below this flexor carpi ulnaris. And then it will be later on, it will be accompanied by the ulnar artery. So the brachial artery will be divided into radial artery, ulnar artery. Ulnar artery will be coming on this side, medial side, and it will be accompanying below it will be joining the radial nerve below the flexor carpi ulnaris, and then it will be going and it will be coming in the subcutaneous plane, and then we'll be entering into the Goins canal. Okay?
Dr. Das,
Yes?
which layer is the supinator muscle in?
Supinator muscle is at the deeper layer muscles.
In the extensor side,
Supinator
on the
muscle
lateral
is
side,
on the lateral side.
on the lateral side. So
Just
along with the
below yes, it is the
along,
deeper layer. It's
so
normally counted in the the anterior surface, volar surface, not on the dorsal surface.
so from the radial to the ulnar side, first would be supinator, then extensor pollicis brevis and adductor pollicis longus.
No, supinator, yes. In that situation, if it is in the deeper layer muscle, that should be counted in the anterior muscles. That means if you are counting the deeper layer muscles, as I was telling you, the ventral muscles, anterior surface muscles are three layers: superficial layers, intermediate layers, and deeper layers. Superficial layer muscle was starting from the lateral to medial was your pronator teres, then comes your the flexor carpi radialis, then your palmaris longus, then your flexor carpi ulnaris. These are the superficial layer. Second layer
Yes,
muscles was your flexor
digital
carpi.
Digital
superficialis.
These are superficial.
superficialis.
Then the deeper layer muscles supinator is your counted.
So
Okay, sir.
where is the
Thank you.
Osborne's ligament, sir? Osborne's ligament.
Osborne's ligaments is between the two head of your flexor carpi ulnaris. So if I'm enlarging it, so this is the two head of the flexor carpi radialis, ulnaris. So this aponeurotic band between these two, head of the flexor carpi ulnaris is known as Osborne's ligament.
So other end of the flexor carpi ulnaris is attached to the ulnar border, sir.
Yes,
One
yes.
is at the epicondyle.
Yes. I'm just showing you what this is the muscle itself. So the flexor carpi ulnaris, it actually lies outside the carpal tunnel, and it lies over the pisiform muscle. If I'm enlarging it, so it runs over the pisiform muscles and getting attached, in the joint capsule as well as in the pisiform. Okay.
Okay, sir.
Like the flexor carpi ulnaris and the flexor carpi radialis. Remember, when we'll be talking about the wrist, this class one we'll be talking. So there are two tendons. One on this side is a flexor carpi ulnaris, and on this side will be flexor carpi radialis. They will be running. It will be running over the scaphoid bone, and it will be running over the pisiform bone. So these are the two important tendons lying just on the two pillars of the carpal tunnel. Okay. So shall I go to the scanning now, or any more questions in the 3D anatomy? If you're having any other further questions, you can put it in the chat box, or series is there to continue the discussions. Give me 5 minutes break, then I'll be joining again. Okay.
Shirish sir, all these muscles we have to mandatorily remember, sir.
Yes, yes. There are not too many muscle, like only like two muscle in the anterior aspect, four muscle in the lateral aspect on each side, and one muscle in the posterior aspect. So how many muscles are there? 1, 2, 4, 4, 8, 9, 10, 11. 11 muscle. Not too much muscle. Anteriorly there is the biceps, and below biceps there is brachialis. Laterally, there is brachoradialis as well as the common extensor tendon, four common extensor tendon. Medially, there is pronator teres and the other common flexor tendon. And posteriorly, there is only one muscle and tendon, that is triceps. So, not too much muscles to remember.
So the scanning part is easy, or we have to keep on doing it again and again to identify which is the right one.
Scanning part, like
You
it's
may.
the learning curve of ultrasound is quite
Okay.
steep. So more you
Steep.
scan, more you will be oriented with the structure, and the diagnosis will be clear. So my advice to you is, whenever you scan, and if you suspect any pathology, you always scan to the opposite side where the patient is not complaining of pain, and try to see the difference between two structures. And in the initial days, I used to do like that. I used to scan at the area where the patient is complaining of pain, and then at the same time I used to scan to the other area where the patient is not complaining of pain, and you can compare that to see the ultrasound sono-anatomical picture of both sides, and then you can determine picture. So this is for the beginners, and later on you will know what are the pathological structures. So in the beginning, always scan the opposite side where the patient is not complaining of pain, and try to see the difference between the structural difference between these two area where you are scanning, and you will be able to pinpoint the pathology. Okay, always scan the opposite side where the patient is not complaining of pain. Then in the beginning, then you'll be able to identify the what is the normal structure and what is the pathological structure, and then you will come to the diagnosis. Okay, that is the trick. Always scan the opposite side and check the normal
Okay.
structure.
Okay, series.
Okay, sir.
Yes, sir.
My volunteer is visible,
Yes, sir.
and the screen is also visible.
Yes, sir.
Okay. So I was listening the question answers. So definitely, more and more again and again, you cannot remember all the muscles, layer by layer muscles. You cannot remember everything, at the beginning. So ultrasound learning is a little bit having a difficult learning curve. So the only trick is you have to have the good 3D anatomy model. That is very, very important. And I always tell, to learn the ultrasound, there is no alternative. You must be having a good the 3D anatomy software. You again have to see again and again at the what is the orientation, how the muscles runs, and also you have to practice the scanning, and then definitely gradually you will be grasping. Okay, so let me try scanning with the anterior elbow, and you can see my volunteer has extended his hand, and this skin crease from where we'll be starting. And remember what was there in the anterior elbow? We'll be seeing the very big pyramidal-like muscles there. That is your brachialis. Okay, and the probe what I have taken is your linear probe, high frequency linear probe, 20 megahertz probe, and my aspect marker is I am keeping it onto the lateral side. That means this side of the lateral side, one actually camera I'm putting it on this medial side, another camera I have kept in the lateral side, so that my hand is not obstructing how I am holding the probe, so that you can have a very clear idea how I am holding the probe. So left side of the screen corresponds to the lateral side of the patient, and I am starting scanning here, and you can see what is there. So there is, I call it as a very big highway. What is that? That is your black line. is your
Island cartilage.
this is the
Hyaline
hyaline.
cartilage.
This is the hyaline cartilage. So this part is your,
Capitulum.
Capitulum.
and this part is your
Trochlea.
Troch-
Trochlea.
And what is the brachialis muscle? The whole, not full part is seen, still little bit on this side.
Trochleus.
The whole is your brachialis muscle. And little bit of this muscle is seen. What is that?
Brachioradialis.
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 Small part is seen here is your
Pronator teres.
Pronator teres.
right. And on the top, what I can see is here I am seeing the
Biceps.
distal
Biceps.
biceps tendon, and this is your
Brachial.
Brachial.
Artery.
brachial artery, and medial nerve is here, not nicely seen. I'll be sliding the probe little bit more medial side, then you'll be seeing it better. Okay, so that is the starting point. That is the home page. Whenever you are lost, you'll be always going back to the home page and you'll be seeing. So if I'm coming more medially, you see here I can see the two head of the radial nerve very nicely. So between the brachialis and the radialis is your the radial nerve. And here you see what I was telling you. This is one head, long head, and this is the short head of the biceps. And then very nicely pulsating nerve is your, this is in this volunteer to volunteer, median nerve. This is a part of the median nerve. There is not able pulsation. If I'm putting the color there, you see, if I'm putting color, so that is a part of the median nerve. See, that is the part of the median nerve. So that is whole is your median nerve. Whole. And then is your, here is your, this muscle is your pronator teres.
Pronator.
This muscle is your pronator teres.
Pronator teres.
Okay. So now here I will be first focusing on the distal end of the radius. Distal end of the biceps. Distal end of the biceps is little difficult. Why? Because it is suddenly dipping down. You see, now I can see both the head hyperechoic. Both lateral head, medial head is hyperechoic. But sometimes if I'm doing that, one head is hyper, one head is hypo. But now this is both is hyper. So short axis identification is okay, but long axis identification is little difficult. So what are the tricks? There are few ways to scan the distal end of the radius. One of them is your anterior. What I'm doing right now, anterior, then medial, then lateral, and then posterior. That means I can see this tendon all by different approaches. So first I'm doing it in the anterior. And for that, I'm putting a the weight here on my patient's the hand, and I'm making little flexed so that the patient is having the the tight the biceps. So now this was the biceps just below my euro marker, and now I am turning my probe into long axis. So this is your long end means biceps tendon, and I am coming and seeing where it is getting attached. Okay, so this is your distal end of the biceps. It's getting attached with the radius. So this is how I am seeing it anteriorly. You see, this is the, and here if you are making it if I'm making it tight, then you can see the distal end of the radius, distal end of the biceps very nicely. So this is the distal end of the biceps getting attached here at the radius. Radius on the medial side of the radius. That's why the radial bone will not be very nicely seen. So this is your distal. This is the anterior how. Now from the medial side, if I'm going little more medial, you see, after the brachial muscle, the long head of the biceps, what is there? So BAM, biceps, then is your brachial artery, and then is the medial nerve. BAM is the mnemonic to remember. So that means just medial to the biceps tendon is your brachial artery. So another approach, which is medial side, I'm seeing, see, so first I'm putting my, so what I'm doing, this was the brachial artery. So I'm putting the brachial artery there, and then I'm seeing the brachial artery in the long axis. So this is the brachial artery in the long axis. Brachial artery is dipping down. So now at this point, if I'm tilting my probe from medial to lateral, then what I can see is here, distal to the artery, I'll be seeing the tendon there, dipping down. Okay, let me put little more gel there. So what I'm doing, I'm putting my probe over the brachial artery. So this is the brachial artery. And once I'm seeing the brachial artery, I'm just tilting my probe laterally. So through the brachial artery, I'll be able to see. So this is the tendon, what I can see. So this is the tendon. So this was the brachial artery, and below that is the tendon what is getting attached. So here, from the medial to see my probe position, how I'm rolling, it was straight, I'm seeing the brachial artery. I'm going medial to the artery, and through the artery, I'm seeing the brachial tendon. So this is the medial approach. And again, here, this approach, the difficulty is here, you cannot do the procedure distal end of the biceps. Your tendinopathy is one of the common cause of the anti-elbow pain. So that you cannot do the procedure, but you can identify the pathology there in that way. Now your lateral approach. Lateral approach is I am putting the patient's hand in the the 90-degree angle. Thumb is looking towards. So how the it will be running? It will be running like that. So what is the superficial muscle here? Here is your brachioradialis muscle. After that, what will be the muscle? Supinator muscle. After that, I'll be seeing this as a let me increase the depth a little bit because here it will be little deeper. So you see, this was your so this is the radius. These are the two heads of the supinator. So this is your brachioradialis, and this tendon is your the biceps tendon. So what I am doing, I am seeing this through the muscle. Which muscles? I am seeing it through the supinator and the brachioradialis muscle. I can see the distal end of the radius, distal end of the biceps, where it is getting attached to the radius. Everybody understood? So this is the lateral approach. You see, this tendon is here, the distal end of the radius. I'm seeing it, and it is getting attached here. And I'm seeing it through the, this is the supinator, and this is the pronator, the brachioradialis. Brachioradialis and the supinator, through that I am seeing the distal end of the distal end of the biceps. So this is another way to see the distal end of the biceps. I'm sure everybody can appreciate it nicely. So I'm holding the probe like this because it is coming like this, and I am seeing the muscle through the tendon through the muscles. Now the posterior approach. Posterior approach is your, so you see how is the whole hand position. We call it as a cobra position. You see? So you see, the now hand is facing towards the patient's face, but what I'll be doing, I'll be making it facing towards me. Okay? So initially it was like that. So I'm doing just like a cobra, he's facing it. And here, now I'm let me again put some gel. So this position is known as the cobra position. And you see, this is, you see, now the radial head is, when the pronation supination, you see, now this tendon what is coming is your distal end of the biceps. You see, now he is, doing the supination, so you cannot see it. Again, now patient is doing the pronation. So the supination pronation, when the radial head is rotated, the tendon is coming out. So if the patient is having the distal end tendinopathy, so you can very easily go for the injection from the lateral to medial. So in that way, I can do the procedure, I can put the injection there, and I can do the injection. So these are the 4 ways to see the distal end of the radius. And for the procedure purpose, it is the posterior approach, which is the most feasible. But to visualize it, lateral approach is the best way to visualize the health and the tendinopathy. So that is how we can see the distal end of the biceps. Now I'll be coming to the other muscles, common flexor, common extensor, and then at last I'll be coming to the different nerves, common flexor, common extensor, and also the posterior muscle, that is your triceps muscles. So first, I'm coming with the common flexor tendons, and common flexor tendon is getting attached where? At the medial epicondyle. So what I'll do, I'll be putting my aspect marker towards the medial epicondyle. I'm keeping the aspect marker towards the medial epicondyle and the distal end towards the thumb or little finger. So, okay, let me remove these triangles. So you see, this is your, let me freeze it, and you see where is my probe? My probe is looking towards the little finger. So if I'm doing like that, then so this was your medial epicondyle. This is your ulna. Here will be your sublime tubercle. So the upper part is your the common flexor tendon, and the lower part is your anterior band of the medial ligament complex. So this part is your anterior band. And you see, when my distal end of the ultrasound probe was facing towards the little finger, then I can see this ligament, anterior band of the medial ligament complex better. You see, I'll be again showing you. So now the probe is looking towards the little finger. You see, these fibers are so nicely seen. So this is your anterior band of the medial ligament complex. Can you appreciate it very nicely? Anterior band, medial epicondyle to the ulna sublime tubercle. So this part, above part is your tendon. But tendon part, common extensor tendon part is better seen if my aspect marker is rotated towards your thumb. And now I am rotating towards the thumb. And now you see, now you can see the tendon part better. So this is the muscle, this is the myotendinous junction. So you can see the common extensor, common flexor tendon muscles and the tendons better if I am rotating my hand, rotating my distal end of the probe towards you. So this is the myotendinous junction. Your needle should come like this, and it'll be the injection. So we should be definitely discussing that to go for the procedures there. So this is the myotendinous junction. This is the common extensor tendon, where for the tendinosis or the golfer's elbow. So that is the site of the injection part. But for the ligament part, to visualize the ligament part better, what I have to do? My probe should be rotated towards your little finger. You see, now the ligament part is very nicely seen. This part is the ligament part. So this is your anterior band of the medial ligament complex. Now let me show the other part of the medial ligament complex. Other part is what? One is your it is forming the floor of the, so this is the okay. So this is the medial condyle. This is the olecranon. So this is your Osborn's ligament. This is your cubital fossa. This is your ulna. And this part of the ligament is your posterior band of the medial ligament complex. So how I was holding the probe? Like this. And my aspect marker is towards the medial side. That means this is your medial side. That is your medial epicondyle. Like this is your medial epicondyle. This is your olecranon, as opposite side. This is your ulnar nerve. And this ligament is the posterior band of the medial ligament complex. Now, transverse or horizontal band is difficult to see, but again, we'll be trying to see it. So first, again, let me come back to this part. You see? So here what I was seeing? Here what I was seeing is your anterior band. I was seeing the sublime tubercle nicely. So this is the sublime tubercle, this is the anterior band. So what I'll do now, I'll be fixing the distal length here and I'll be moving this proximal length aspect marker towards the olecranon. So I'm just fixing it over the sublime tubercle and now I'm rotating my bone, my distal length, sorry, proximal length towards the olecranon. Okay, so now this bone, so this bone was the sublime tubercle and this is your olecranon. So this ligament is your horizontal. Between these two bony prominence, this is your medial ligament complex. So now, let me come to the lateral side. That is your common flexor tendon. So the same way, I'll be putting the aspect marker towards the medial lateral condyle. How I'm holding the, how is the patient's hand? Thumb is looking upwards and I am holding the probe here. Let me reduce the depth a little bit so that you can understand it nicely. Okay. So it's a nice image. So this is your condyle, lateral epicondyle. And this is your radial head. This black line is what?
Annular ligament.
No, this black area.
Hyaline cartilage.
Cartilage.
Yes, hyaline cartilage. Annular ligament is on the top of that. This is the annular.
Okay.
So this is your common extensor tendon. Upper half. And the lower half, this is your what?
Lateral, radial,
Lateral collateral ligament.
lateral collateral.
Lateral collateral ligament.
Radial collateral ligament. It's
Radial
a part
collateral.
of lateral ligament complex. So you can see the two ligaments here. One is your radial collateral ligament. This is your annular ligament. So these are the two components, and third component I'll be showing. So again, what I'm doing, lateral ligament complex, and out of that lateral ligament complex, out of that one is your the lateral radial ligament, another is your annular ligament. So now let me put more gel. So I'm fixing the proximal end of the my probe over the lateral condyle. And now distal end, instead of radial head, I'm moving towards the ulna. Okay, so you see here, this was your condyle, this was your ulna, and this ligament is your
Lateral ulnar collateral. Lateral ulnar collateral.
Ulnar collateral.
So that is the third component of the lateral ligament complex. And at the top of that, there is a muscle. What is this muscle? Who can tell?
This will be anconeus.
Yes.
Anconeus.
So, I was holding the probe like this. So this is your anconeus muscle. Right. Very good. So now I'll be coming to the other forearm muscles and the nerves. I'll be showing when I'll be tracing the nerves. Now let me come to the posterior. And I'm putting a camera to polished shoulder. Balista pore abar lagbe. Camera to fix kore. So look how, let me increase the depth a little bit. Okay, see how I am holding the probe? Correct. Right. So my aspect marker is proximal. That means right hand side is the proximal side and the left hand side is the distal side. So right hand side proximal side, left hand side distal side. So what will be the what is this then? This is the distal part. What is this?
Ulna. Olecranon.
Olecranon process.
Olecranon process.
This is the olecranon fossa and this is the central tendon of the triceps.
Triceps.
So this is also a part posterior approach. You can go ahead with the joint injection in that way as well. So this is the joint part. And if I am seeing it in the short axis, that is the long axis. If I am seeing it the short axis, I am putting my aspect marker towards the medial side. So remember what was the muscle layers? Superficially,
Lateral and long head.
Long head and medial head.
and deeper was your
Medial head.
Yes. So this is your long head. This is your the lateral head, and below is your
Mid.
Okay. So now I'll be tracing the individual nerves.
So will you please show that again? Head of triceps.
Okay. I'm going little still more. So this part is your medial part.
Radial head.
Almost whole of that. This part is your the radial lateral part, and this head is your the medial. Sorry, long head. This is the long head,
Long.
medial head, and this part is
Lateral.
your medial.
Okay. Okay.
Lateral, medial, and long. Long and lateral is on the superficial layer, and the medial head is on the deeper.
Okay.
ক্যামেরাটা আবার অ্যাডজাস্ট করতে হবে So let me first trace the median nerve. Okay. Okay, I forgot to show you another very important thing is your lacertus fibrosus. You see, this is your lacertus fibrosus. It is from the distal end of the radius. So the biceps tendon, sorry, biceps, and it goes above. So this is your this aponeurotic band. This is your lacertus fibrosus. Understood? And this whole is your median nerve. I'm following that median nerve. Can you appreciate that median nerve?
Yes, sir.
And this artery is your one artery, another artery. What is this two artery? 1, 2. I'm putting color, you see, because this is a big artery.
Lateral artery divided into anterior,
Radial and ulnar.
ulnar.
Okay. So you see here it was 1 and now getting divided. And now
Yes.
follow the radial nerve.
Median.
Okay, follow the radial nerve. Sorry, median nerve. Now median nerve is entering into the, so this muscle was the pronoid teres, huh? This muscle was
Yes.
pronoid teres. And this muscle was your brachialis. So now, initially it was between the brachialis and the pronoid teres. The nerve is here, between the brachialis and the pronoid teres. After that, after the brachialis is ended, so the nerve is now entering into the two head of the pronoides. So now here it is a two head of the pronoides. So this is, now it is entering between the two head of the pronoid teres. So follow the nerve. This is the nerve. Now it is between the two head of the pronoid teres, one head and another head. Now you see here, the anterior interosseous nerve is getting separated here. This is your anterior interosseous nerve. Main median nerve, let me follow it. Then I'll be coming to the anterior interosseous nerve. So now the median nerve is coming below the, second layer muscle was what? First layer muscle, second layer muscle was what?
Second
Second
layer
layer
Digitorum
digitorum
superficial.
Yes.
Superficial.
So now the nerve is below the flexor digitorum superficialis, and so these two, let me just feel it and show you. So this is the nerve. Radial artery has gone medial side. Now it will be very soon accompanied by the radial, with the ulnar nerve. So this was your first layer muscle. This was your second layer muscle. Second layer muscle is what?
flexor digitorum superficialis.
Digitorum superficial.
And this is your deeper layer muscle. So this muscle is what?
Flexor
Flexor
digitorum profundus.
Profundus.
Flexor
And
pollicis.
on this side, another deeper layer muscle is coming. What is this?
Flexor
Flexor pollicis
Flexor
longus.
pollicis longus. So now here you see the medial nerve is last lying between this is the first layer muscle. This is the second layer muscle. This is the third layer muscle. This is also third layer muscle. So now the nerve is lying below the flexor digitorum superficialis, above the flexor digitorum profundus, and medial to the.
Flexor pollicis longus.
Very good. So now I will be following the nerve further. Let me put more
It was
gel.
not divided yet, na sir?
Already divided. I told you where the anterior interface nerve has left. I'll be following the anterior interface nerve later on. You see, again come from here. Follow the median nerve. I'm keeping it in the middle of the screen.
Yes, sir.
It's divided.
No, still not divided. So now it is entering into the two head of the pronoid teres. You see here.
Okay.
Yes,
Two
sir.
head of the pronoid teres, and then now it is, anterior interface nerve is coming below. This is your anterior interface. Can I appreciate that?
Okay.
This one. That will be going most towards the lateral side. This is the anterior interface nerve. Okay? And it will be accompanied by artery. Already some pulsation has started. And the main median nerve is here.
Okay.
And now median nerve is in, and ulnar artery is going more laterally. Median nerve is here, and you see anterior interface nerve is here. It is accompanied by artery. Can you appreciate the artery?
Shit.
This
Yes,
is the
sir.
median nerve, and here is the anterior interface nerve. And now I am coming down. Okay. You see, can you see the patient is moving the thumb, and you can appreciate that. What is your flexor pollicis longus?
Pollicis longus, yes, sir.
Flexor
And
pollicis longus is moving.
move the fingers. Now he is moving the fingers. So flexor digitorum
Mhm.
superficialis and profundus are now moving.
Profundus
And
is
the nerve
moving,
is
yes.
here. So this was the
Yes.
first layer muscle. This is the second layer muscle. This is the third layer muscles. This is also deeper layer, third layer muscles. And nerve is here. So now I am following the nerve again. Just one more. And now the median nerve is coming. Now it is coming superficial, and now it is entering into the carpal tunnel.
Carpal tunnel.
Next part we'll be discussing on the next class. So this was the nerve, radial nerve. Again, I'm going back towards the elbow. You see how it is going, how it is going. This is the nerve, how it is going. And here the interosseous nerve is coming down here. This is the main median nerve, and this is the interosseous nerve coming down and laterally. Now I'll be tracing the interosseous nerve. So this was the interosseous nerve coming laterally down and accompanied by the artery. This is accompanied by the artery.
Interosseous artery.
Let me check whether color is taking, because this is a very tiny, sometimes it is not taking the artery. Okay. It is accompanied by the artery. So this is the anterior interosseous nerve. You see, this is the anterior interosseous nerve. Okay. Now it is nice to see anterior interosseous nerve. Now it is becoming very thin and difficult to trace further. Clear?
Yes, sir.
Now let me go to the ulnar. Ulnar, what I told, it runs below the osborn ligament, below the what?
Below the
Two heads of the flexor carpi ulnaris.
flexor carpi ulnaris.
So you see, this is your ulnar nerve, and now I'm coming. So now you can see which muscle is this?
Flexor
This
carpi
is
ulnaris.
flexor carpi
Ulnaris,
So
ulnaris.
it will be coming below the flexor carpi ulnaris. So this muscle is flexor carpi ulnaris. Understood? Can you follow the nerve? And now you
Yes,
see
sir.
the radial artery is, ulnar artery is coming. Can you appreciate that?
Yes,
Ulnar
sir.
artery.
Yes, sir.
Yes.
This is the nerve. And now the nerve and artery lies together. And now it is entering into the Gwen's canal. Can you appreciate
Yes,
the
sir.
nerve and artery now together? So the Gwen's canal part will be discussing next day. So this was your ulnar artery, ulnar nerve. You can see the long axis as well. I forgot to show you the long axis of the radium. So this is the long axis. You see the long axis of the nerve. So this is the nerve. This muscle is your flexor carpi
Flexor
ulnaris.
carpi ulnaris.
So this is the nerve. This is the nerve. Okay, let me show you the long axis of the median nerve as well. So median nerve was here. Now I'm making it in the long axis. Median nerve. I'm making it in long axis. So this is the nerve. Long axis advantage is you can understand the thickening of the nerves, whether it is, this is the long axis of the nerve. Now come to the radial nerve. Radial nerve, I'll be tracing the deep and superficial individually. First, let me trace the deep, and then I'll be coming to the. So first, let me come to the home page. Remember this home page? Okay, so this was the home page. This muscle was
Brachialis.
brachialis. This is
Brachialis.
the brachioradialis. So this is the
Brachioradialis.
branch,
Brachioradialis.
right? And there is one artery there. Huh? This artery will be coming later on, coming crossing. This artery is going, and the superficial and deep branches, artery is going above. So I'm pressing the deep branch. Huh? This is the deep branch. This is the deep branch. Now it is entering into the radial tunnel between the two heads of the supinator. So this is the nerve. When it is between the two heads of the supinator, the nerve will be flattened. It is almost universal. In every patient, I have seen that volunteer. So this is the deep branch. And this deep branch will be flattened once it is entering between the two heads of the supinator. You see? Now between the two heads of the supinator. And after that, what will happen? It will come in the dorsal compartment. This is the nerve. Jelly there. So I need to put gel. I cannot compromise on that. Okay. So that was the deep branch. Appreciate? So it is between
Yes, sir.
the supinator. What is this muscle?
Brachioradial.
Brachioradialis.
Brachioradialis, right. So now, can you follow the nerve here? Deep branch.
Yes, sir.
It is actually divided already two. It depends on the volunteers how. So one of the deep branch is here, another deep branch is here. Now it will be coming below the
Supinator.
extensor digit. It is supinator is here. After that, it is coming out. This is the supinator muscle.
Okay.
So now after that, the supinator is over. Now it is coming. This muscle is your extensor digitorum muscle. And below that, second layer muscle, extensor indicis muscle. So can you appreciate?
Yes, sir.
One branch is going there, and another branch is coming deeper. That will this muscle is your extensor indicis muscle. This is your extensor digitorum muscle. So now this branch is now already known as, it is no longer deep
Interosseous.
radial now. It is now
Dorsal interosseous. Posterior
Posterior
interosseous.
interosseous now.
posterior interosseous. Now it will be, you see, now it is dipping down. This muscle was what? This muscle was
Indicis.
what? This is
Ex
extensor digitorum. This
above one is
is extensor indicis.
extensor digitorum
And coming
and
below.
extensor
Now it will be
indicis.
coming below the extensor indicis also. You see, now it is coming extensor indicis, below extensor indicis. And then in the dorsum, so it is coming here. And see, here is your terminal branch. Here it is already extensor digitorum is tendinous. Extensor indicis will be muscular. Extensor indicis will be becoming tendinous later on. So this is the four, extensor digitorum. And this is your extensor indicis. So it comes below the extensor indicis. I'm putting the color. Let me see whether it is taking color. It is here. Not taking color nicely. So this is the, I hope you can appreciate the pulsation there. So that is the terminal branch of the, artery and the nerve together. I'm showing you. Can you appreciate that? It is not taking the color, but it is pulsating. So artery and the nerve together. And just above that, what is that muscle? Is your extensor indicis.
Extensor digitorum
This
minimi.
is the tendon of the extensor digitorum minimi is here. This
Okay.
is the indicis.
This
And
is
above that is your
Digitorum
extensor
superficialis.
digitorum.
digitorum.
Extensor digitorum, 4 tendons are there, and extensor indicis.
Sir, any
And
clinical significance, sir?
clinical significance means posterior
Sir,
interosseous nerve entrapment. That is the clinical
okay.
importance.
Okay, sir.
Normally, it is not entrapped in this. This is just for your, understanding how the nerve is going on, to understand the anatomy. And now I'll be showing you the superficial branch. So again, let me start from my home page here. You can appreciate that superficial branch. That is
Yes,
superficial. And now let me follow that. It will be below the brachioradialis muscle. Artery is moving. This is your superficial branch. Can I appreciate?
Yes, sir.
Jail is not there. Okay. So again, let me come from here. This is the superficial branch. I'm coming, superficial branch. Just follow the superficial branch. Artery is moving below and passing away. This was your nerve. I'm keeping the nerve in the center. This was your nerve. This was your nerve. Now it will be coming between the radial artery and the radius. Now the nerve is very nice. Nerve fascicle is very nicely seen. Can I appreciate the nerve very nicely? That
Yes,
is the
sir.
nerve. And now it will be coming over the radius to come into the, you see, now it is coming over the radius to come the dorsum of the hand. Okay, rest part will be showing in the next class. Rest part. Okay, so this much from my side. Anything you wish to say again?
So
Sir, I
posterior
want to see
interosseous.
again.
Which one?
Posterior interosseous.
Posterior interosseous. Okay. So posterior interosseous is we have to follow the
Posterior
Radial.
interosseous.
deep
Radial.
branch, following the.
D branch. D branch.
You can appreciate the two branches nicely together and one pulsating artery. So this is your
Yes.
deep branch. Follow that. It will be entering into the two head of the supinated. Now it is in between the two head of the supinator. This one. And as I told you, when it will be entering, you see this is rounded, nerve is rounded now. But when it will be entering into the two head of the supinator, nerve is flat. And this happens almost everywhere. Again, when it will be coming out of this, again it will be rounded. You see now it is rounded.
Yes.
Yes.
Here is the nerve. Huh? And now the
Yes.
nerve is below the flexor digitorum. Here is the nerve. So this is your extensor digitorum, this is your extensor indicis.
This is
Nerve is here. And now it will be going down.
Below the extensor indices.
Yes. It will be going below the extensor indicis. In this area, it is not very nicely visible. But again, when it will be going distally, this part here, it is visible again nicely. So here you can see the artery pulsations. Artery pulsation is now very nice to see. Because as I told you, both anterior interosseous and the posterior interosseous nerve accompanies the artery. Name is same, anterior interosseous artery, posterior interosseous artery. Okay, I hope everybody can appreciate the artery pulsation. In the middle of my screen. Yes. So that is the
Yes,
terminal
sir.
blank of the posterior interosseous.
Sir, I want to see the medial collateral ligament, all bands, anterior, posterior.
Okay. Much well it. Okay, anything in the dorsal, because I have put a lot of gel in the dorsal side. Otherwise, I'll be just wiping off all this gel. Much well.
so when we do the procedure, so much jelly has to be applied actually, sir.
No. To visualize the small nerves, it is very difficult to see all those small nerves. So that's why I'm putting a lot of gel. But otherwise, in the doing the procedure, you cannot put the gel because your gel will be inside the cover.
Sterile. Yes, sir. That's what, sir.
So this is just to demonstrate you nicely, That's why I have put a lot of gel so that you can visualize it nicely. Okay. So what I'm doing, I'm putting let me reduce the depth so that you can appreciate it better. Okay. I'm putting my aspect marker over the
Medial epicondyle.
And as I was telling, if I'm putting the distal end towards the thumb, you can see more. This was the area of when the muscle is seen very nicely.
Yes.
If sliding it towards the little finger, you see, now I can see the ligament part very nicely. So this is your anterior band. Understood who told me? Please ask me this question.
Yes, sir.
This is your anterior band. Above that is the common flexor tendon.
Yes.
And below part is this part is your anterior band. Right? So now what I'll do, I'll be fixing the distal end over this bony prominence, the sublime tubercle of the ulna. And what I'll do is I'll be sliding the proximal element, this meant I'll be sliding over the olecranon.
Okay.
Please go. So this was your sublime tubercle, this was your olecranon. So this ligament, white ligament, this is your horizontal or transverse band.
Transverse band. Okay, sir.
And then posterior band is again very easy. I'm putting the aspect marker over the medial epicondyle. Or which so this is your the epicondyle and this is your olecranon. So this is your roof of this, that is your Osborn ligament, and this is your, not all is seeing, whole part is seeing hyperechoic, but you can easily trace the fibers. So this is your posterior band.
Posterior band. Okay. So for transverse band, we have to keep the aspect marker over the ulna, then we move towards the olecranon. Then we are
This
able to see
proximal end,
the
you move towards
transverse.
olecranon. From the medial epicondyle, you go to the olecranon process.
Okay. Thank you, sir.
Okay, so this much from my side. Now over to series.
Yes, sir. Thank you very much, sir. Excellent demonstration, sir.
So I am stopping the sharing now. Now over to Dr. Series.
Sir, is the slide visible, sir?
Yes, it's nicely visible.
Sir, first, we would like to, all of us like to congratulate you for getting Lifetime Achievement Award, sir, in this musculoskeletal ultrasound congress in Pondicherry, sir. Congratulations.
Thank you so much. Thank you so much.
So with this, let us start some elbow pathologies. I'm Dr. Sirish. So unlike shoulder joint in the elbow, there are not too much of pathologies which are there, but there are few common pathologies that you should be knowing. Okay. So in elbow, like there can be problem associated with the joint, which is commonly known as arthritis. There can be problem associated with various ligament that sir has just shown, mainly the medial and lateral ligamental complex. There commonly there will be pathologies associated with the medial and the lateral this extensor as well as flexor tendon around the elbow. The insertion of the biceps as well as insertion of the triceps are also common pathology pain generators. And there are various nerves, like mainly the median and ulnar nerve as well as radial nerve, which passes from arm to forearm. And while doing so, there can be impingement of these nerves, causing various peripheral neuropathies. And there are few bursas around this elbow joint, mainly the olecranon bursa as well as cubital bursa. So these can be also common source of pathology. Okay, so whenever patient comes with elbow pain, so in this right-sided picture you can see various color code and probable pain generators, which can also give you a clue what are the pain generators that might be giving discomfort to the patient. Okay, so if the patient complains of anterior aspect of elbow pain, then the problem may be associated with the biceps tendon. Mainly the biceps tendonitis can be the major problem. So if the patient complains of pain in the posterior aspect of the elbow, then the structures there will be the triceps and olecranon bursa. So the triceps tendonitis as well as olecranon bursitis can be a problem. So if the patient comes with the problem in the lateral part of the elbow, then the tennis elbow is the most common pathology that you may encounter. Similarly, if the patient complains of the medial side of the elbow pain, then the golfer's elbow or common flexor tendon associated pathologies you may be encountering. And if the patient complains of pain which is radiating from the elbow towards the forearm and then to the hand, then various nerve entrapment, ulnar, median and radial nerve entrapment might be the source of pain. Okay, so first one, elbow arthritis. In arthritis, like in any other arthritis, patient will complain of pain, swelling, stiffness of the joint, or clicking or snapping of the joint, especially if there is a fluid around the joint. And patient will also complain of pain, which is exacerbated when the forearm is extended or rotated. So these are the common problems that the patient will come to you in pain clinic. So coming to common elbow arthritis, unlike shoulder joint or unlike knee joint, where the arthritis is usually the degenerative arthritis, here in the elbow joint, most common cause of arthritis is rheumatoid arthritis. So rheumatoid arthritis is an inflammatory arthropathy which can cause elbow pain in most of the patient, and the age group of the patient will be usually young patient, but it can also be in the elderly group also. But most commonly, young patient will come with pain in the elbow joint, and you do have to take good history regarding the inflammatory history, like any family history of the inflammatory arthropathy or morning stiffness or if the pain is coming down with the NSAID. So these are the clues that you'll be getting in patient with rheumatoid arthritis involving the elbow joint. And patient here also will complain of pain and around the elbow joint. They will complain of episodic swelling of the elbow joint, as well as you may encounter in the radiograph various joint erosion as well as inflammation. Inflammation may be appreciated during the examination. So another type of arthritis is osteoarthritis. Here, since the elbow joint is not weight, not a weight bearing joint, so here osteoarthritis, primary osteoarthritis of elbow joint is less common than knee and hip joint. But here again, osteoarthritis can be there, especially if it is related to sports or work. So if there is excessive use of elbow, like in cricket player or in the baseball player, in these players there is excessive use of elbow, especially the bowlers. So these bowlers might have osteoarthritis in the later part of their life because of wear and tear of the especially the elbow joint. So these are also called post-traumatic osteoarthritis of the elbow joint, because it is secondary to repeated trauma, to the micro trauma or macro trauma to the elbow joint. But if you compare the osteoarthritis, the degenerative or primary osteoarthritis of knee and hip joint, the third common is the elbow joint. The first is knee joint, second one is a hip joint, because these are the main weight bearing joint. And since elbow is non-weight bearing joint, normally post-traumatic primary osteoarthritis can be there due to the repeated wear and tear of the elbow joint. And gouty arthritis can also be the common pain generator in elbow pain. So here also patient will complain of pain, swelling, inflammation, and if you take good history, he might correlate this pain with various food intake, like if the patient is taking too much of red meat or alcohol. So in these conditions, patient might have a bout of attack of uric acid and have a elbow pain. Okay, so regarding arthritis, the secondary osteoarthritis in the elbow joint is much more common than the primary osteoarthritis. So in this picture, you can see, if you see in the right side of picture, you can see various stages of osteoarthritis of the elbow joint. So if you see the picture in the right side, 0. So this is the normal architecture of the elbow joint in the Sono-anatomy. You can see the good distal end of the humerus, and you can also see the radial head, and you can see the articular cartilage over the capitulum. And you can also see the capsule, okay, over the articular cartilage, hyaline articular cartilage. But if you compare that with the right side of the picture, you can see the capsule has been distended up, and there is an anechoic structure between the capsule and the joint. So this basically means there is a effusion in the shoulder joint, and this is from the anterior aspect of the elbow joint, anterior aspect of the elbow joint. But if you see the bony structure, there is no erosion of the bony structure. So this is the early osteoarthritis of the elbow joint, especially the radiocapitular joint. Okay, so the distal end is the radial head, the proximal part is the distal end of the humerus. So this is the capitular joint, and you can see because of the effusion, the capsule has been distended. So if you see the lower part of the picture here, in addition to the distension of the capsule as well as effusion in the elbow joint, you can also see some irregularities at the over the head of the radius. Okay, so this is the moderate osteoarthritis of the elbow joint. Here, if you come see the right side of picture, here also you can see erosion at the distal end of the humerus. Okay, as well as effusion, which is distending the capsule. So this is the moderate osteoarthritis of the elbow joint. But if you see the lower part of the picture, you can see distinctly there is marked erosion of the distal end of the humerus as well as the proximal part of the radius. And you can, in addition to this, you can also see the capsule being distended with the fluid. And similar to the right, the last picture also, you can see the head of the radius, there is a large osteophytes coming from the head of the radius, and it is protruding outside, and you cannot clearly identify the distal end of the humerus. And there is also effusion and distension of the capsule. So these are the various stages of the osteoarthritis of the elbow joint. So in the first picture is the normal picture. Then the level 1 picture is basically the early osteoarthritis of the elbow joint, where there is only distension of the capsule and the effusion. But in moderate osteoarthritis, you can easily see the erosion in the either in the distal end of the humerus or in the proximal part of the radius, at the head of the radius, as well as effusion and distension of the capsule. But in severe osteoarthritis, you can see marked erosion on either side of the joint, as well as distension of the capsule, as well as effusion. And you may also encounter big osteophyte protruding and basically pinching the capsule, and you can also see the effusion. So and in the left side of the picture, you can also see nicely, you can see the capsule has been distended. The yellow arrowhead basically shows you where the capsule is, and below this yellow arrowhead, that means below the capsule, you can see the effusion between the proximal part of the radius and the distal end of the humerus. You can nicely see the effusion. So these are all the pictures of the effusion as well as arthritis of the elbow joint. So this is the recent picture that I saw in a 19 years old female. So April, she came in April in pain clinic, and you can see the left side is, you can see this is the olecranon fossa, and you can see a bird beak-like structure that is a tip of the olecranon, and this is basically the posterior part of the elbow joint, where you can see the central tendon of the triceps. Okay, and you can see the olecranon fossa, and in olecranon fossa you can see hypoechoic structure which is coming from the posterior part of the elbow joint, and it is displacing the fat pad. And in the right side, this is the normal picture. So this is the posterior elbow of mine, and I'm comparing that with the patient. Okay, and you can easily see in the normal patient, the entire olecranon fossa will be having fat pad. Okay, but if there is any effusion from the elbow joint, the effusion will be coming out, and then this fat pad will be displaced by the effusion. So in the left side, you can see effusion of the elbow joint from the posterior side. So this is from the anterior aspect. Okay, so this is from the anterior aspect. You can appreciate the fluid as well as distension of the capsule from the anterior side, and this one is from the posterior side of the elbow joint, where the effusion is coming into the olecranon fossa and displacing the fat pad, and the right side picture is the normal side. So actually this young lady had effusion on both elbow joint, and she was diagnosed as rheumatoid arthritis. And I didn't go for aspiration of the fluid. I thought of referring this patient to the rheumatologist, so that once the rheumatological issues is controlled, then maybe the effusion will come down. And even after the DMRDs and the rheumatoid arthritis part is not taken care of, then only I'll go. I was planning to go for the aspiration of this effusion in the elbow joint. So these are the right and left side of the elbow joint of the same female patient, and you can see on both sides, you can see a big fluid coming out of from the elbow joint posteriorly, and it is displacing the fat pad. So here you can appreciate this red dotted line is basically the boundary of the fluid, which is displacing the fat pad from the posterior side on either side, on both sides. Okay, so this is the big effusion that I encountered in a 19 years old female who was having rheumatoid arthritis. So another picture here, in this picture you can see sometimes there are foreign body or loose body in the elbow joint, which can cause pain as well as effusion in the elbow joint. So in the left side of the picture, this is the short axis view of the olecranon fossa, and you can see this upper part is the triceps muscle. Okay, but just below that you can see the hyperechoic and hypoechoic rounded structure. So basically these are the loose body which was found inside the posterior part of the elbow joint, and because of this loose body, it was creating too much of friction, and that's why patient was having pain and big because of repeated friction and pain, patient also had effusion in the posterior part of the elbow joint. So here you can see. So this is the normal elbow of the patient, and from the posterior side, and in the left side you can see triceps. Below the triceps you can also appreciate loose body within the olecranon fossa, and because of this loose body within the olecranon fossa, there was complete repeated friction of this area between the olecranon head and the loose body when the patient was doing flexion and extension of the elbow joint. And because of this repeated flexion and inflammation, you can also see fluid coming out from the posterior part of the elbow joint and displacing the fat pad. And this is the normal elbow of the same patient. So here, because of the loose body, it was irritating the capsule. It was causing friction whenever the patient was doing flexion and extension, and because of this inflammation, there is a effusion which is coming out from the posterior part of the elbow joint into the this olecranon fossa. So this patient was advised to go for surgery and remove this foreign. You can easily see this is the rounded dumbbell-like structure or structure. This rounded structure is a loose body which is within the this elbow joint. Okay, and we advise the patient to go for a surgery and excision of this loose body, because only after the excision of this loose body, which was causing all this problem in the elbow joint, this patient's pain as well as swelling would be subsided. And after the excision of the foreign body or loose body, even after that, if the patient is having effusion and pain, our plan was to give was for aspiration of this effusion if there is any, and then inject PRP into the elbow joint. So that was the plan in this patient. Okay, so here normally the osteoarthritis of the elbow joint is not that common, but here there is one picture of the osteoarthritis of the elbow joint. You can see the X-ray picture, and you can see severe osteoarthritis of the this ulna as well as the distal end of the humerus. You can see osteophytes, marked osteophytes at the anterior as well as in the posterior aspect, and you can also see the joint space has been severely reduced between the olecranon process and the distal end of the humerus. Okay, so this is the X-ray picture, and if you see the right side, this is the ultrasound picture where you can see thickened capsule, and you can also see the distended capsule between the ulna and the humerus. This is from the anterior aspect, and you can see stretching of the capsule because of the effusion due to the severe osteoarthritis of the elbow joint. And you can also see in these conditions, we basically go for we'll put the needle into the joint and aspirate the effusion. Okay, in plane needling into the joint space from anteriorly, and we aspirate the effusion, and after aspiration of the effusion we can put a small amount of PRP, about 2 ml of PRP in this joint to take care of pain and regeneration. But this is the severe osteoarthritic elbow, so whether the patient will benefit with PRP or not, it's not that clear. But whenever you encounter the effusion in the anterior aspect, you can simply put the needle in plane needling and then go into the area where there is fluid. We aspirate the fluid and inject either steroid with local if it's inflammatory, and if it's the purely degenerative, we can inject PRP into this ulnotrochlear joint of the elbow joint. Okay. So now another common pathology in the elbow joint is the tennis elbow. So tennis elbow is the most commonly encountered pathology in the elbow joint. Okay, so this is previously it was known as epicondylitis, but since there is no inflammation, now epicondylitis is no more valid terminology. Now we are calling it as a lateral epicondylgia. So lateral epicondylgia is the more scientific term for the tennis elbow, but we commonly call it as a tennis elbow. And you have already seen the anatomy as well as sono-anatomy, where you saw the common extensor tendon. Okay, so these in this picture you can see common extensor tendon, starting with extensor carpi radialis brevis. So extensor carpi radialis longus is not a part of common extensor tendon. You can see the upper part of the this muscular part is the extensor carpi radialis longus, which is not a part of common extensor tendon. So common extensor tendon starts with extensor carpi radialis brevis and extensor digitorum, extensor digiti minimi, as well as extensor carpi radialis ulnaris. So these are the four muscle which forms the common tendon, and it is attached to the upper 2/3 part of the lateral epicondyle. So there can be tear in the this tendinous part of the common extensor tendon, which can give rise to tennis elbow. So see, if you see the epidemiology of tennis elbow, it is quite common in general population. It usually the incidence is about 1 to 4.3%, especially in our part of the world. Basically, the female population tends to have more this tennis elbow because they do all household job. No, they do cleaning, washing, everything they do. So in female, these are more common, especially in our part of the world. And if you see the incidence, it is about 1 to 4.3%. But in tennis player, because of continuous wear and tear of this common extension tendon, almost in 50% of the people who are playing tennis will have tennis elbow. So that's why it is named as tennis elbow, commonly named as tennis elbow. And in tennis elbow, basically patient complains of pain and the lateral aspect of the elbow just over the lateral epicondyle, and if you palpate this lateral epicondyle, it will be severely painful. And there is one test known as condemns test, okay, which is also positive in this tennis elbow. What the examiner is doing is, patient is asked to forcefully extend the wrist, okay, here against the resistance. So examiner is giving resistance and the patient is asked to forcefully extend the wrist joint, and once the patient does forceful extension of the wrist joint against resistance, patient will have a pain in the lateral side of the elbow joint. So this is called as tennis elbow test, which is also known as Cosen's test, and these two things will be positive in tennis elbow. And previously we used to rely only in these two tests for tennis elbow, but nowadays with the advantage of ultrasound in pain medicine, we can easily see this common extension tendon, like sir has demonstrated, and we can encounter various tear or just tendinosis in the common extension tendon, and we can diagnose it very easily. Okay, so here you can see this is the macroscopic view, and in the right side there is a microscopic view of the common extensor tendon. Here you can see here you can see the common extensor. This is the myotendinous junction of the common extensor tendon, and after the muscle part is ending, the tendon is coming and then it is attaching to the lateral epicondyle, upper 2/3 of the lateral epicondyle, and you can easily see our tendinosis as well as tear. So tear is basically demonstrated by this star asterisk like structure, and this arrowhead basically is encircling arrowhead is basically signs of tendinosis. Okay, so this is the degeneration, and this one, the asterisk mark, is basically tear within the common extensor tendon. So this is a typical picture that you will be encountering in a patient with a tennis elbow, and this is the macroscopic picture. But if you see the right side, you can see the microscopic. So you can see the tear, and as the grade of the tear increases, the size of the tear is also increases. So this is the macroscopic picture of the tennis elbow or lateral condylalgia. Okay, so normally when you are doing ultrasound, you might get confused between like tendinosis and tendinitis. Okay, so itis means inflammation, tendinosis is basically degeneration. So in normal, this is the upper part, is the picture of the ultrasound picture of the normal patient, where there is neither tear or degeneration nor there is inflammation. Okay, so in this picture, if you just put a ultrasound probe, you can see a good echogenicity of the tendon, and there is no, and if you put a color Doppler also, there will be no lighting up of the color Doppler. So this is in the normal case. But if you see the second picture, here you can see when you put the collar Doppler, there is a lighting up of the collar Doppler in the picture. So so this means there is inflammation within the common extensor tendon, but there is no tear within the common extensor tendon. So in the inflammatory in the tendinitis, there will be instead of tear, you can encounter red color lightening of this common extensor tendon when you put a collar Doppler. And if you see the third picture here, if you just put the probe, you can easily see the hypoechoic structure within the common extensor tendon, and you can see marked hypoechoic structure within the common extensor tendon. So there is a degeneration of the common extensor tendon, and along with degeneration, there is also tear within the common extensor tendon. And if you put a collar Doppler, since there is no inflammation, there will be no lighting up of this common extensor tendon when the collar Doppler is turned on. But if there is combination of both, that is degeneration, tendinosis along with tendinitis, you will be seeing both structure. You will be seeing lighting up of collar Doppler with this within the common extensor tendon, and you will be also seeing the hypoechoic structure as well as tear within the common extensor tendon. So these are the various type of ultrasound picture that you might encounter in patient. Okay, so normal picture, so normal tendinous attachment, no hypoechoic structure within the tendon, and if you put a collar Doppler, there will not be any lighting up of this collar Doppler. In the inflammatory pathology, and there is no if there is no degeneration, the echogenicity of the tendon will be like the type 1. Okay, but in addition to this, when the collar Doppler is turned on, there will be lighting up of the collar Doppler. So in third picture, there is only degeneration and there is no inflammation. Okay, so if there is only degeneration and there is no inflammation, then you will see the degenerative changes like tendinosis you will be seeing. Okay, and then you will be also seeing like hypoechoic structure, which is basically tear. But if you put a collar Doppler, you will not be seeing any lighting up of the collar Doppler here. But in the last picture, you can see combination of both tendinosis as well as tendinitis. Okay, so there is a degeneration, there is a tear, as well as there is a increase in signs of inflammation, hyperemia within the common extensor tendon. Okay, and so basically this is another picture where you can see calcific deposition within the common extensor tendon. So this calcific deposition can happen in any tendon, and this common extensor tendon is not there is here also this is the common area where the calcific deposition might happen in the common extensor tendon, and it can be seen in the X-ray. You can see the calcified part of the common extensor tendon in the X-ray, and you can also see this in the ultrasound. So here you can see, because this is a bone, there is a posterior acoustic shadow. So there is there's a hyperechoic structure will be seen within the common extension tendon, and below that, because this is bone, there will be posterior acoustic shadow which is created by this bone. So this is the typical picture of calcific this lateral epicondylitis. Okay, calcific tendinitis or tendinosis of the common extensor tendon. So here also this is the picture taken by me recently. Here you can see comparison between the normal common extensor tendon and the degenerated common extensor tendon. So right side of the picture you can see this is the normal elbow of the patient. As you can see, skin subcutaneous tissue, just below the subcutaneous tissue you can see hyperechoic structure, uniform hyperechoic structure getting attached to the lateral epicondyle in the upper 2/3 part. But if you compare that with the another part, another side of the elbow where the patient is complaining of pain, you can nicely see the difference between these two structures. Here the common extensor tendon is not hyperechoic, it is hypoechoic, and within this hypoechoic structure you can also see the tear within this tendinosis. So the left sided picture is the tendinosis along with tear of the common extensor tendon, but in the right side this is the normal structure, normal sono-anatomy of the common extensor tendon. Here also you can see in the left side, lower left side of the picture, you can see comparison of the same picture. Okay, so here there is a normal common extensor tendon getting attached to the lateral epicondyle, upper two-third of the lateral epicondyle. But if you compare that with the left side picture, you can easily see the change in echogenicity of the common extensor tendon. And you can also see, if you see carefully, you can also see the tear within the common extensor tendon. So this is the typical picture of the patient with tennis elbow or lateral epicondylalgia. Okay, so if you encounter these type of patient, you can easily put PRP in the tendinosis part as well as in tear to take care of pain. So here also you can see nicely, you can see tear, a big tear extending to the up to the myotendinous junction of the common extensor tendon. Here, this picture is of the same patient of the right and left elbow. Okay, in the right elbow, you can see the normal common extensor tendon getting attached to the upper two-third of the lateral epicondyle. But if you compare that with the left side picture, you can easily see a big hypoechoic this defect within the common extensor tendon. So this is the very good picture which shows a big tear in the common extensor tendon, which is almost basically extending to the up to myotendinous junction. And you can see the radial collateral ligament is intact here. So lower one-third is the radial collateral ligament. Okay, but the upper two-third you can see a hypoechoic structure, anechoic structure extending from the site of attachment towards the myotendinous junction. So this is the high degree tear of the this common extensor tendon. So this is also another example of the tennis elbow. So here I'm basically showing one video where there is combination of all everything. Okay, in this video you'll see the recently I took this video where the patient came from USA for injection of PRP. In US he did 2 episode of steroid injection, but he was not having good pain relief, and you'll find out why he is not having pain relief, because he was diagnosed only as a common tennis elbow. But in our examination we found that there is a tear in the radial collateral ligament also. So, and there is a marked this calcification within the common extensor tendon. Okay, so this is the recent video of a young guy in which we injected PRP, and tomorrow we are going for the second session of PRP in this patient. Okay, so let us so this is the muscular part of the extensor tendon. Now you can see the joint, and you can see I'm going above. You can see the calcific deposition within the common extensor tendon, and I would like to. You can also see effusion. You can see I'm just stopping here. Okay, you can also see effusion within the elbow joint. Okay, you can see tear of the radial collateral ligament here later on in the picture, and you are also seeing the calcific deposit within the common extensor tendon. Okay, and you'll also see the tear at the site of attachment in this patient. So everything is here. Calcific deposit is there. There is a tear at the site of attachment. There is a tear of the radial collateral ligament which was missed in the previous scan, and there is also effusion in the elbow joint. Okay, let us see those. So you can see the effusion in the joint. So you can also see the tear. You can see a nice tear at the site of attachment. Okay, and you can also see calcific deposition. You can see a hyperechoic structure within the. So here I would like to stop here. You can see a nice tear at the site of attachment. You can see it looks like it has been ripped off from the site of attachment. So this is the tear at the site of attachment of common extensor tendon. And you can also see later on in this picture, you can also see defect in this radial collateral ligament as well in the same patient. So you can see nice tear at the center of the screen where the common extensor tendon is attaching with the lateral epicondyle. Okay, and here you can see tear in the radial collateral ligament also. So you can see the defect. Okay, here and this is the tear in the radial collateral ligament. So there is a combination of both tennis elbow. Along with that, there is a tear of the radial collateral ligament. Okay.
Sir,
Yes.
sir, in this patient, did you do any irrigation for calcification or only simple
No. I
PRP?
didn't do any. I just put PRP. I'll show you the picture. I'm just putting PRP.
So what about calcification then?
Excuse me.
What about calcification? It will be there or it will subside?
So normally calcification, if it's soft, then we can just put PRP around the calcified area and that will take care of pain. Otherwise, unfortunately, we have to remove if still after injection of PRP, if the patient is complaining of pain, unfortunately, either we have to go for barbotage technique where we have to scrap the calcified
Irrigation.
part and do the irrigation, which might not be commonly, which might be bit difficult if it's a hard calcification. It is only possible in case of soft calcified structure, okay? Or the patient might have to go for surgical excision. If it is still giving pain, patient may have to go for surgical excision of the calcified part. Okay, first usually I go with PRP around the calcified part because that is the most easy part. And if it's not helping, then I counsel the patient to go for a barbotage technique where I scrape the this calcified part with the needle and then go with the normal saline irrigation. Okay, but this is not always possible. It is only possible if the calcified part is a soft calcification. If it's a hard calcified part, I usually go with the duloxetine and go for pain management and take care of pain. Or if it's not helping, then patient has to be referred for the excision of the calcified structure. Okay, Nilima?
Thank you, sir. Thank you, sir.
I'll be showing you the injection around the calcified part also. Okay,
Okay.
so this you have already seen. Now you can see here in this picture, you can see a nice tear at the site of attachment of the common. Can you see this tear at the site of attachment of this
Yes,
common
sir.
extensor tendon? Okay, so here is a good tear. This is of the same patient. Okay, so you can see the needle coming from this caudal side, piercing the common extensor tendon, and you can also see the needle coming up to this site of tear and PRP being injected. So this is of the same patient. Okay, you can see needle coming from caudal part towards the lateral epicondyle. Okay, you can see needle is coming, and then near to this area, I'm depositing basically PRP. Can you see needle coming close to this here? Can you see the needle coming to the area of tear? And you can see nice reverberation
Yes,
artifact
sir.
also. So
Yes,
here
sir.
I'm basically giving PRP here because this is the site of tear. So the needle is done from caudal part and towards the lateral epicondyle where there is tear, we have to direct the needle, okay, in plane, and wherever there is tear, we are basically depositing the PRP. So, and another picture of the same patient. Okay, there is a tear, and you can see in the same patient there are lots of calcified part because maybe. Okay, you can see osteoarthritis also. There is a erosion of the distal end of the articular surface. Okay, you can see needle coming here also. I'm depositing PRP here, and also I'm depositing PRP around the calcified part. Can you see the bulk of the this common extensor tendon is increasing as I'm depositing PRP there. Okay, another picture here. I'm depositing PRP in the common extensor tendon. Here you can see the calcified part. Okay, and you can see the needle coming and then the PRP being deposited around the calcified area. So yes, this patient has already received 2 times steroid in US, but still he was having pain because the diagnosis was not complete. They just diagnosed this as a tennis elbow, but in this video you can nicely see the tear in the radial collateral ligament, the osteoarthritic changes at the in the elbow joint. So here you can see I'm depositing PRP, okay, at the area of tendinosis as well as wherever there is this calcified area, I'm depositing PRP. So yeah, this is the same picture. You can see my needle is coming near to the calcified area. I'm doing repeat multiple tenotomy. Oh, yeah, I'm puncturing this tendon multiple time, and after that, I'm basically injecting PRP here near to the calcified area. So tennis elbow is the most common pathology that you will be encountering in terms of elbow pain. Okay. So here PRP is being injected here. Okay. And here common extension already shown, I think. Okay, now this is the picture which I wanted to show you. Here in this picture you will appreciate I'm depositing PRP in the common extensor tendon, but this PRP is seeping into the joint because of the tear in the common extensor tendon. So this is the real reason why I'm showing this picture. Okay, you can see PRP will tickle into the joint space because there is a defect in the radial collateral ligament as well in the same patient. So as I'm depositing PRP at the site of tear, okay, you can see this is the site of tear. So I'm depositing PRP here. This is the lower part is the radial collateral ligament. Okay, I'm just giving a small amount of PRP. And now you can see PRP will be going. Can you see the defect? Can you see the just now?
Yes,
Uh,
sir.
yes, you can see now I'm depositing just
Yes.
now. I'm freezing. You can see PRP going to into the joint because of the tear in the common extensor tendon as well as radial collateral ligament. Otherwise, once you are depositing PRP in the common extensor tendon, it will not go into the joint if the radial collateral ligament is intact. But here, because of the tear in the radial collateral ligament, you will be seeing the PRP which is being injected here is going into the joint. Okay, same patient. Okay, like just see there is a tear in the radial collateral ligament, and now you can see the PRP will go. Can you see PRP going into the joint? This white structure.
Yes, sir.
Okay, so this is the case of there is everything calcification, tear, tendinosis, as well as injury to the radial collateral ligament. Okay, so another this is the tennis elbow is the most common pathology in the elbow, which patient will come with the lateral elbow pain, but we don't go directly with PRP. We basically manage it conservatively. Okay, conservative management consists of rest. Okay, and avoid squeezing, gripping, or holding heavy object. You can go with the short duration of NSAID, and there is a tennis elbow band which is available in the market. We can also go for the tennis elbow band, and we have to refer the patient for physiotherapy for tennis elbow exercise. And even after the conservative management fail, that means if rest, NSAID, and physiotherapy fails, then only you go with the injection. Don't go with the intervention in the first visit. Okay, so similar to this, in the medial elbow pain is also quite common, but not as common as the lateral elbow pain. So patient can come with the medial elbow pain also, which is also known as golfer's elbow, which is also known as medial epicondylgia. Here you can see pain and redness and pain. Okay, mainly the pain in the medial side of the elbow joint, that is just over the medial epicondyle. So you have already seen in anatomy the orientation of the common flexor tendon, starting from pronator teres, flexor carpi radialis, okay, and palmaris longus and flexor carpi ulnaris. So all these tendon basically converge to the medial epicondyle. And if there is any tear of this common flexor tendon, sorry, at the site of attachment, then it will give rise to the golfer's elbow. And similar to this, you can see in the right side the microscopic picture of the tear within the tendon of the common flexor tendon. Okay. So here you can see a patient usually complains of the pain in this medial epicondyle. When we palpate this medial epicondyle, there will be tenderness at the medial epicondyle, and this pain is basically reproduced when the wrist is flexed under resistance. In tennis elbow, what we do, we extend the wrist against resistance. But in flexor, this golfer's elbow, what we do, we flex the wrist against resistance. And when the patient does this, flex the elbow against resistance, then the patient will have pain at the medial epicondyle. So this is the golfer's elbow test, and you can also appreciate tear in the tendon of the pronator teres as well as flexor carpi radialis in this picture. So basically, there will be tear at the common flexor tendon which is attaching to the medial epicondyle. So here also, if you encounter these patients, you usually start with conservative management with rest, NSAID, ice, immobilization of the elbow, and physiotherapy. And if this is not yielding you good result, then only you go for the injection of PRP wherever there is tear. So in this picture, you can see the upper picture is the normal picture where you can see the muscular part of the common flexor tendon get converting to the tendinous part and getting attached to the this medial epicondyle, and lower part is basically the anterior band of the ulnar collateral ligament. Here you can see this upper picture is basically the common flexor tendon, and lower greenish part below this two is basically the common flexor tendon, and the lower part is basically the anterior band of the ulnar collateral ligament. And in the lower part you can see the pathological structure where you can see tear within the common flexor tendon, and here you can see tendinosis where it is inflamed, hypoechoic, as well as there is small tear within the common extensor tendon. So this is tendinosis with tear, and the left side picture is only tear in the flexor tendon, which is golfer elbow. So, can you just identify the difference between the tendon of the common extensor tendon and common flexor tendon? So, can you identify the difference here between the common flexor tendon and common extensor tendon?
So this looks much thicker actually.
Yes. Thicker means the tendinous part of the common flexor tendon is very small. If you compare that with the lateral side, the tendinous part will extend up to the joint in case
Yes.
of this common extensor tendon. But in case of common flexor tendon, the muscular part is more and the tendinous part is very small, which is exactly
Yes.
opposite with the common extensor tendon, where the tendinous part, you can see the tendinous part up to extending up to the joint, and then only the myotendinous junction starts. Okay, but here golfer elbow, you can immediately tell which side, whether it's a medial side of the elbow or lateral side of the elbow, because in the medial side tendinous part is very small and muscular part is more dominant, whereas in common extensor tendon the tendinous part is long and then comes the muscular part. So this can be a clue in the spot diagnosis whether it's a medial epicondyle or lateral epicondyle. Just see the extent of this tendon. If it's short, then it is common flexor tendon, and if it's long tendinous part, then that must be the picture of the lateral side of the elbow, that is common extensor tendon. And you can see tear within the common flexor tendon. Here you can see tendinosis, hypoechoic structure. In addition to that, there is a small micro tear within the common flexor tendon. Okay, here the needling is same as that of common this one tennis elbow. You can see the position of the probe, okay, directed towards the this thumb or little finger, and by which we can nicely see the myotendinous junction and the small tendinous part of the common flexor tendon. And you can see the needle from caudal to cranial side, basically going towards wherever there is tendinosis or tear. You just put a needle in plane and you can inject PRP around the tendinosis or tear to take care of pain. You can see the position of the probe, the angulation of the needle, as well as you can also see the in-plane needling has been done, and you can see the path of the needle, okay, going through the muscular part. Finally it is coming to the tendinous part, and deposition of PRP wherever there is tendinosis or tear. So this is the normal treatment, but done after the conservative management fails. Okay, so now coming to the various ligaments, this tear in the various or sprain or tear in various ligament around the radius or ulna can also be source of pain generator. Okay, so in the lateral elbow, you just saw three ligaments are there. Radial collateral ligament is there, lateral ulna collateral ligament is there, and annular ligament is there. So these are the structure of the ligament. Sir has nicely demonstrated how to identify this radial collateral ligament, lateral collateral ligament, and you also saw the annular ligaments. So these ligaments basically provide stability to the radial head, as well as radius and the distal end of the humerus. So these are the basically the supporting structure which will stabilize the joint. But in case of blunt trauma to the elbow, or basically in case of sports related activity, there can be sprain or tear in these ligaments. And whenever you encounter this tear and sprain in these ligaments, you do have to go for MRI to see the complete extent of this extent of the injury. And if it's a partial tear or sprain, you can individually target this ligament and put PRP. But if it's a complete tear of this ligament, then you do have to refer to the hand surgeon, okay, orthopedic doctor, for the reconstruction of this ligament. So like any other ligament, if there is sprain or partial tear, then we can take care of that issue with the injection of PRP. But if it's complete rupture of this ligament, then unfortunately the patient might have to go for the surgery. So these are the three main ligaments. Then these ligaments can be a source of pain. Okay, so here you can see with the structure. I've also shown you the anterior or radial collateral ligament. You can see here there is a tear in the radial collateral ligament. So if you see the lateral epicondyle, upper 2/3 of the lateral epicondyle gives attachment to the common extensor tendon, and lower 1/3 of this lateral epicondyle gives attachment to the the ligament, mainly the lateral ligament or the radial collateral ligament. And you can easily see, so you can see this plus or asterisk mark here, where you can see this is the entire thickness of this radial collateral ligament. Okay, and you get the position of the probe. You have already seen how sir was showing you the radial collateral ligament, and in the right side of the picture you can see the lateral this lateral ulnar collateral ligament also here. So you might encounter thickness of this ligament or tear in this ligament while doing ultrasound. And if you encounter this structure, please go for MRI, see the full extent. If there is complete tear, go for a referral of the patient. And if it's partial tear or sprain, you can individually target this ligament and inject PRP in these ligament if there is any pathologies. Similar to that, in the lateral side, in the medial side also, there is a medial ligamental complex, and there are main three ligaments. The most commonly injured ligament is anterior band of the medial ligamental complex, because this anterior oblique or anterior band of the ligament is the most strongest ligament and is the main ligament which stabilizes this medial part of the elbow. So commonly the anterior band can be a common site of pathology where there can be sprain or tear of this anterior band. Okay, so you can also see the structure of the anterior band here, and you have already seen nicely with ultrasound how sir was demonstrating you the all three medial ligamental complex. Okay, so here also you can see this is the medial side, and the upper part is the flexor muscle, and this the tendinous part getting attached to the medial epicondyle, and the lower part you can see the anterior band of the medial collateral ligament. Okay, so this is the ulnar collateral ligament, basically the anterior band of the ulnar collateral ligament. And if you find any sprain, this will look hypoechoic. If there is any tear, it will be anechoic, cleft. So if there is any hypoechogenicity or anechoic cleft within this ulnar collateral ligament, you can scan this as you are scanning the this common flexor tendon. And you can easily target the area where there is hypoechogenicity or anechogenicity, and you can inject PRP in this ulnar collateral ligament. Okay, so here you can also see the position of the patient as well as position of the probe for identification of this ulnar collateral, especially the anterior band of the ulnar collateral ligament. And sir has very nicely said, if you target the distal end of the footprint towards the little finger, then you will be getting a very nice view of this anterior band of the medial collateral ligament. You can see the position of the probe, and you can see that probe is directed, distal part of the probe is directed towards the little finger. But if you just rotate it, and if this probe is directed towards the thumb, then you will be seeing this the common flexor tendon very nicely. Okay, so here you can see the examiner is basically pointing the probe, distal part of the probe towards the little finger. That means he is basically evaluating the anterior band of the medial ligamental complex. Okay, so these are some pathological picture you can see. So this is the normal structure of the this anterior band of the this ulnar collateral ligament, medial collateral ligament, and in the right side you can see hypoechogenicity and thickening of this the ligament. So this is basically a sprain within of the anterior band of the medial ligamental complex, and in the lower part you can see tear, you can see hypoechogenicity as well as tear within the and this anterior band of the ulnar collateral ligament. In the right side of the picture you can also see a complete tear where the tear is extending through and through from the upper part of the ligament. Tear is extending up to the lower part where it is where it is getting attached. So this is the full thickness tear of the, not complete but full thickness tear of the this anterior band of the ulnar collateral ligament. And you can also see the partial tear of the this anterior band of the ulnar collateral ligament where the tear is within the center of the or within the center of the ligament. But in the, if you compare this with the right side of the picture, you can see the tear is extending up to the this one common flexor tendon also. So this is the complete full thickness tear. This is the partial tear of the ligament anterior band, and this one is just the sprain of the ligament where there is anechogenicity, okay, hypoechogenicity, and you can also appreciate thickening or enlargement of the anterior band of the ulnar collateral ligament. And in the right side you can see the normal structure of the ulnar collateral ligament. So starting from upper left side, normal side, upper right side just the sprain, in the lower side left side there is a partial tear, and in the right side there is a complete tear or full thickness tear of the ulnar collateral ligament. So if there is sprain and if there is tendinosis as well as or if there is a partial tear, then you can just inject PRP here. But if you encounter this kind of picture where there is a complete through and through tear of the anterior band, then you may have to go for a surgical reconstruction of this ligament. Okay, so coming to various nerve, you just saw there are three nerves which is coming from arm to forearm. Okay, so these two nerves are the radial and the median nerve, which comes from anterior side of the arm. Then it goes from the antecubital fossa, it goes to the forearm. Similarly, from the posterior side, ulnar nerves come from the posterior side, and then in the posteriorly it goes to the from arm to forearm. So basically, starting with median nerve. So we all know that median nerve arises from the medial as well as lateral cord of the brachial plexus, and it runs down medially along the this brachial artery and vein. Then initially it lies just below the laceratus fibrosis, which is basically the fibroaponeurotic band which is arising from the tendon of the biceps. Okay, so this is one of the site where it can get compressed, but then it goes down and then it goes between the two head of pronator teres. So these are the two potential site where the median nerve can be entrapped. One is at this level, okay, B, where there is marked as B, where there is a laceratus fibrosis which can compress this median nerve, and another is between this E and F, okay, from C to F, where the median nerve is traveling between the two heads of pronator teres. So these are the two potential site where the median nerve can be entrapped at the level of elbow. One is at the level of laceratus fibrosis, okay, where this fibroaponeurotic band can compress the median nerve. Another is while it is traveling between the two heads of pronator teres. So these are the two potential sites where the median nerve can be compressed. And when the median nerve is compressed in this area, it is known as pronator teres syndrome. Okay, so you just saw a very nice picture of how to trace median nerve in the elbow. Here also I'm just saying this upper left side picture is, you can see median nerve is just next to the brachial artery, and it is below the lacertus fibrosis. You can see this is the brachial artery, and in the left side of the brachial artery, this is the hypoechoic structure, is the tendon of the biceps, and from the tendon of the biceps you'll see that arch which is covering the this brachial artery median nerve, and it is going above the this pronator teres. Okay, so here this is one of the site of impingement of the median nerve because of thickening of this lacertus fibrosis. You can see this is the honeycomb like structure is the median nerve. So here there can be entrapment of movement of median nerve, and after that it basically goes, initially it lies between the brachialis and pronator teres. Here you can see, so you can see the it is going below as we trace this median nerve from elbow or from arm to forearm or from cranial to caudal side. You can see initially the median nerve is between the pronator teres and brachialis. So this is not the common site of entrapment, but as it goes below, then it basically in the lower left side picture you can see the median nerve basically travels between the two head of pronator teres, the humeral and ulnar head of the pronator teres. So this is the most common site of entrapment of the median nerve, okay, between two heads of pronator teres. So this is the short axis view, and in the right side of picture is the long axis view. So this is the long axis view of the median nerve as it is traveling between the, initially between the brachialis and pronator teres, and later on between the two head of the pronator teres. So this upper part that is just below the lacertus fibrosis is one of the site of entrapment of the median nerve. Another is in between the two head of pronator teres where the median nerve can get entrapped, okay, and it gives a condition known as pronator teres syndrome. So pronator teres syndrome is a condition which is caused by compression of the median nerve between the two heads of pronator teres, okay, and basically patient will complain of pain and numbness along the volar side of the elbow, forearm, and the lateral 3.5 fingers, including the palm of the thinner aspect of the palm of the hand. And the most common cause of this is basically trauma at the proximal part of the forearm, or if there is any hematoma at the proximal part of the forearm secondary to trauma, or if there is a hypertrophy of these pronator teres muscles, or if there is any congenital anomalies at the level of the elbow. So these are the common cause of the pronator teres syndrome, okay. So here also the same picture has been repeated. Here in pronator teres syndrome, there is compression of the median nerve between the two head of pronator teres. So the left lower side picture is the site where there is compression of the median nerve as it is traveling between the humeral head and ulnar head of the pronator teres. So this is the short axis view, and in the right side is basically the long axis view of the median nerve. You can see easily see, so as rightfully said, you can see exactly at which place the median nerve is entrapped in this long axis view, because there will be abruptly there will be swelling. Once there is compression of the median nerve, there will be swelling of the median nerve, and you can easily see the caliber of the median nerve as it is passing between the pronator teres and brachialis initially, and then it goes into the two heads of the between the two heads of the pronator teres. So this is the most common site of entrapment of the median nerve, and you will be seeing enlarged hypoechoic median nerve if there is any compression of this median nerve at this site. So here also you can see the another common site is just below the lacertus fibrosus. So you in this picture you can see from the tendon of the biceps the aponeurotic band will come, which will cover this the brachial artery, median nerve, as well as the flexor tendon, and this lacertus fibrosis will basically merge with the antecubital fascia of the forearm. So this fibrotic part of this band will merge with the fibrotic part of the forearm, and this is the another site of impingement of the median nerve. Here also you can see the white arrowhead basically shows the lacertus fibrosis, okay, and it basically arises from the tendon of the biceps, and it covers the brachial artery. This red rounded structure is the brachial artery, and just to the lateral to that okay, or just medial to that, sorry, just medial to that is this honeycomb like structure which is shown with this yellow arrowhead is the site of the median nerve. So the here, if this fibrotic band is compressing, this median nerve will be enlarged over here, not in between the two ends of pronator teres. So this is another site of compression of the median nerve, and the clinical presentation as well as a clinical presentation with both pronator teres syndrome and compression of the median nerve at the level of lacertus fibrosis is exactly the similar. It is very much similar. So, but the difference is you can see the median nerve can be compressed at the site of the wrist, which is known as carpal tunnel syndrome, and median nerve can be compressed at the level of this pronator teres, at the level of elbow, which is known as pronator teres syndrome. So you can see the difference between the compression of the median nerve at these two sites. So in case of carpal tunnel syndrome, patient will complain of pain at this wrist, okay, and patient will have tingling numbness of the lateral 3.5 fingers. It usually do not involve this the thinner aspect of the skin over the thinner aspect of the hand, okay. But in case of pronator teres syndrome, you can see tenderness in the proximal part of the forearm, and patient will have neuropathic pain of the entire 3.5 digit of the hand, including the thinner surface of the palm. So why this is so? Can anybody answer why there is tingling and numbness in the entire aspect of the palm and 3.5 finger in case of pronator teres syndrome, but there will be only tingling and numbness, predominant tingling and numbness over the finger, 3.5 lateral 3.5 finger in case of carpal tunnel syndrome? Can anybody answer this? You'll get a chocolate if you answer
Because
this.
is it related to the
Huh?
posterior interosseous nerve? So the posterior interosseous nerve is not yet given out about, sir. So because of
And
that.
if the answer is wrong, you have to give me chocolate, okay? In high class. So this is wrong answer. So I win. I get one chocolate. So
That
check. Do you want to answer?
there is a superficial branch that comes up around 6 centimeter proximal to the carpal tunnel.
Yes. So what is that branch name? What is that nerve name?
Superficial.
Anterior interosseous nerve.
So 2 chocolate for me. This is also no wrong answer.
The palmar cutaneous.
Palmar cutaneous branch of
Yes,
median.
palmar cutaneous.
Yes, this is the answer, okay? So you can see the palmar cutaneous branch of the median nerve basically goes into the from forearm to this hand, above this, not below the flexor retinaculum, above the flexor retinaculum. So in case of carpal tunnel syndrome, the palmar cutaneous area will not be there will not be problem in this area because compression is at the level of wrist. But if the compression is at the level of elbow, it will be involving this palmar cutaneous branch also, as well as main median nerve also. So in case of pronator teres syndrome, patient will have numbness, pain to the entire 3.5 finger as well as this thinner area of the palm. But in case of carpal tunnel syndrome, this because the palmar cutaneous nerve is already going into the hand above the this ligament, so this area will not be painful in case of carpal tunnel syndrome. But in case pronator teres syndrome, including 3.5 finger, the thinner surface, skin over the thinner surface will also be having pain. Okay, so you got the answer. So this is one of the clinical diagnosis to differentiate between the compression of the median nerve at the level of elbow and at the level of the wrist. Okay, so at the level of elbow, the entire light as well as dark green area will be painful. But in case of carpal tunnel syndrome, only the light green area of the hand will be painful, not this dark green area. Okay. Okay.
Yes, sir.
Okay. Okay, so here also, like any entrapment neuropathy, if you encounter any compression of the median nerve, we can just use 5% dextrose and go for hydrodilation of the nerve, or we can also use our old one, that is lignocaine and steroid. Also, we can inject around the nerve where there is entrapment, and this can take care of pain in this patient. So another is basically the ulnar nerve. Actually, the ulnar nerve basically arises from median cord of the brachial plexus, and then basically it goes from arm to forearm from the cubital tunnel. And you have already seen cubital tunnel roof is formed by the Osborn's ligament, and floor is formed by the posterior band of the ulnar collateral ligament. So this is one of the site where there can be impingement of the ulnar nerve as it is passing through this tunnel, osseous fibro-osseous tunnel. So this is fibro-osseous tunnel because upper part is the fibrotic part and the lower part is the bone part. Okay, this fibrous band above the ulnar nerve, that is the Osborn ligament, can compress this one. Another is basically this arch of flexor carpi ulnaris. Okay, superficial, and so here also there can be impingement of the ulnar nerve as it is passing from arm to forearm. So this is common problem, especially when we are using mobile too much nowadays. So use of this mobile too much, especially with flexed hand, can cause this entrapment of ulnar nerve at the level of elbow joint. And if there is any entrapment of this ulnar nerve at the level of elbow, it is known as cubital tunnel syndrome. And this cubital tunnel syndrome is the second most common entrapment neuropathy. First, can you tell me which one is the most common entrapment neuropathy? Can you guess which
Carpal
is?
tunnel syndrome.
Yes,
Carpal
median
tunnel.
carpal tunnel syndrome is the most common compression entrapment neuropathy, and second most common is this cubital tunnel syndrome.
Cubital.
Yes, cubital tunnel syndrome, where the ulnar nerve is compressed at the cubital tunnel, especially because of the fibrous Osborn ligament as well as the arc of this flexor carpi ulnaris. Okay, so possible causes of this cubital tunnel syndrome is various bone fragment after fracture, loose body or within the elbow joint, which can irritate this ulnar nerve, or spur arising from the elbow joint, especially after the osteoarthritic elbow joint. If there is any space occupying lesion like tumor, ganglia, hematoma, or if there is any accessory muscles like anconeus muscle, accessory muscle, this can also cause impingement of this ulnar nerve. If there is any synovitis of the elbow joint because of the fluid, it can compress the elbow, this ulnar nerve, and cause cubital tunnel syndrome. Okay, so there can be dislocation. Frequently, there can be dislocation of the nerve in this area. If there is any tear of this Osborn ligament, then the nerve can come out of this cubital tunnel. Frequently, come out of this tunnel and cause this cubital tunnel syndrome. So here in the cubital tunnel syndrome, you can see the course of the ulnar nerve. It comes from arm to
एक दिन खाउनु भयो एक छाक दिन पनि हैन एक
So you can see the normal course of the ulnar nerve from arm. It basically comes from behind this medial epicondyle, then it comes to forearm. So this is the site of impingement. And whenever there is impingement of the ulnar nerve at the level of the elbow, you can see the neuropathic pain extending from the elbow up to the ulnar side of the forearm, and then little finger and the lateral half, medial half of the this ring finger. So these are the structure that will be affected, and patient will usually complain of pain in the ulnar side of the forearm and the hand. So neuropathic pain will be there. Okay, so here patient will be complaining of the pain in the medial side of the elbow, and patient will also complain of tingling, numbness, and paresthesia along the medial side of the forearm as well as medial side of the hand, which involves the little finger and the medial side of the half of the ring finger. Okay, and in long standing case, there can be weakness of the intrinsic muscle of the hand, because the intrinsic muscle of the hand can is supplied by the ulnar nerve. And if there is a chronic entrapment of this ulnar nerve in this cubital tunnel, there can be claw hand because of basically palsy or weakness of the intrinsic muscle of the hand. So claw hand can be seen in the long standing chronic case. Okay, but in acute case or in case of early phase of cubital tunnel, patient will only complain of pain, numbness, tingling along the ulnar side of the forearm as well as on the ulnar side of the hand. So you can easily identify, locate the ulnar nerve at this cubital tunnel and measure the cross section of the ulnar nerve at the level of cubital tunnel. And the normal cross section area of the ulnar nerve at the cubital tunnel is between 5 to 9 millimeters square. Okay, if this cross section area is 10 or above 10, then it is if provided there is any symptom of this numbness, paresthesia along the ulnar side of the forearm and hand, then you can diagnose this as a cubital tunnel syndrome. So nowadays we are measuring the cross section area of this ulnar nerve at the level of cubital tunnel, okay, to diagnose the cubital tunnel syndrome. Previously we used to rely on nerve conduction test. Okay, so nowadays because of the ultrasound we can easily measure the cross section area and determine whether there is determine whether there is cubital tunnel syndrome or not. And this has a sensitivity and specificity of 88%, so it is quite good. Just by measuring the cross section area of the ulnar nerve, we can easily diagnose the case of cubital tunnel syndrome, provided there is symptom. Okay, so and whenever we encounter these conditions, we can easily inject 5% dextrose or like local anesthetic agent and steroid around this ulnar nerve to take care of this entrapment neuropathy. Okay, or we can inject 5% dextrose, or we can inject steroid and local anesthetic agent around this ulnar nerve to take care of the cubital tunnel syndrome. Now coming to third nerve, that is radial nerve. So radial nerve also comes from this arm to forearm, and you have nicely seen how Sir was tracing the radial nerve right from the this antecubital fossa, and then you saw the nerve going into the this supinator muscle, and you also saw the deep branch of the radial nerve coming out from the supinator muscle. So as the radial nerve, you can see this is the radial nerve. In the right side picture, it is basically dividing into superficial and deep branch. Okay, so deep branch of the radial nerve, once it pierces this supinator muscle, then it is called as posterior interosseous nerve. Okay, so compression of the radial nerve before entering into this supinator muscle is known as a deep branch of radial nerve, and once it enters into the supinator, then it is called the posterior interosseous nerve. So, and this you can see, this is the radial tunnel. The length of radial tunnel is about 4 to 7 centimeter, so it is quite long. So anywhere between the entry point, so in the entry point there is a ligament known as arcade of force. So there's a thickening of this ligament, so the proximal part of the supinator muscle is thickened, so this is known as arcade of force. Okay, this arcade of force is one of the potential site of entrapment of the deep branch of radial nerve. Another site is between these two heads of the supinator muscle. So these two heads of supinator muscle, if there is any hypertrophy of this either a part of this two head of supinator, it can compress the posterior interosseous nerve or the deep branch of radial nerve, and it can give rise to the radial tunnel syndrome. And you always have to understand that this radial tunnel syndrome is also quite common. So this radial tunnel syndrome can mimic this tennis elbow, because in both tennis elbow as well as in case of radial tunnel syndrome, patient will complain of pain in the lateral side of the elbow. So in this picture you can see in the middle type of picture, you can see in the tennis elbow tenderness will be exactly over the lateral epicondyle. Okay, but in case of radial tunnel syndrome, the tenderness will be about 2 to 4 centimeter distal to the lateral epicondyle. And this radial tunnel syndrome is also commonly known as persistent tennis elbow, because we usually encounter patient with tennis elbow without any ultrasound or MRI diagnosis, and patient usually have, in case of radial tunnel syndrome, patient usually have history of injection over the common extensor tendon, thinking that it is the tennis elbow. But even after repeated injection of PRP or steroid at the common extensor tendon, patient is not having pain relief, And in these conditions, you must think of radial tunnel syndrome, because radial tunnel syndrome is also known as persistent tennis elbow, and it is commonly misdiagnosed as tennis elbow, because tennis elbow, the incidence is quite high. 1 to 4 to 5% of the common population will have tennis elbow, but the radial tunnel syndrome, the incidence is very low, less. So once patient comes with lateral elbow pain, we blindly diagnose this as a tennis elbow. But sometimes the lateral elbow pain can be due to the radial tunnel syndrome. Okay, so you just have to keep in mind that radial tunnel compression at this there's radial nerve compression, especially the deep branch of radial nerve or posterior interior osseous nerve compression in the radial tunnel can give rise to lateral elbow pain, and this pain is usually radiating towards the forearm. And in case of tennis elbow, maximum tenderness will be at the level of lateral epicondyle, but in case of radial tunnel syndrome, maximum tenderness will be at the level of radial tunnel, that is about 2 to 4 centimeter below the lateral epicondyle. You can easily see the course of the radial tunnel. It is about 4 to 7 centimeter long, 4 to even 9 centimeter long. Okay, so it starts from this arcade of Forche, which is basically thickening of the this supinator muscle, distal end of the supinator muscle, and then it travels between the two head of supinator muscle, and finally it comes out and go to the dorsal compartment of the forearm. Okay, so here you can see the picture of the normal picture, and in left side you can see the deep branch of radial nerve, which is thickened and hypoechoic, and it is within the supinator muscle. So this, and but if you compare with the normal side, here you can see normal size of the radial nerve, deep branch of radial nerve, and if you compare this with the left side picture, you can easily see big hypoechoic enlarged deep branch of radial nerve between the two heads of pronator teres. So this is the typical picture of the radial tunnel syndrome, which is also known as persistent tennis elbow. Okay, so there is a small video where I have traced this same patient, traced the deep branch of radial nerve as well as giving injection. Okay, please see the video. So you can see the deep branch of the radial nerve passing through. You can easily see this is the enlarged deep branch of radial nerve. So you can see I'm tracing the deep branch of radial nerve, and as it goes into the supinator, can you see? It is enlarged. Can you see big? So I'm basically stopping here. Can you see? This is the hypoechoic round structure is the deep branch of radial nerve. So just as soon as it enters to this round supinator muscle, see the change in the size of the deep branch. Okay, just appreciate the change in the site. Okay, see, up to here the diameter of the radial nerve is normal. So this is the radial nerve, deep branch of radial nerve, size is normal, and it has crossed the arcade of Frosch. And once it enters into this supinator muscle, see the change of the diameter. It suddenly becomes big. Can you appreciate this? Suddenly it is become bigger. Can you appreciate this big hypoechoic deep branch of median nerve, radial nerve, as it passes into the two heads of the supinator muscle? So this is the typical ultrasound picture you'll be getting in case of radial tunnel syndrome. So I'm just putting color doubler to basically to rule out this is any artery. Okay. You can nicely see. Now you can see needle coming from lateral to medial side. You can see needle just below this, and basically I'm giving 5% dextrose around this deep branch of radial nerve. Here you can see this is the radial nerve. You can see needle coming from lateral to medial side, and basically I'm giving 5% dextrose around this deep branch of radial nerve. Can you see? I'm giving 5% dextrose slowly around this deep branch of median nerve, and it has an excellent result. So I'm basically giving 5% dextrose slowly around the above and below the deep branch of radial nerve. Okay, Okay, so this is how we go for hydrodilatation around the radial nerve. Okay, so here radial tunnel syndrome, specifically we call it radial tunnel syndrome if it is compressed. The deep branch is compressed before entering into the supinator muscle. That means if this supinator muscle arc, if it is compressing the deep branch, then we call it as a radial tunnel syndrome, where the patient will have pain as well as weakness. But in case of posterior interosseous nerve syndrome, PIN syndrome, where there is compression of this deep branch of radial nerve between the two ends of supinator muscle of radial tunnel, it is called posterior interosseous nerve syndrome, PIN syndrome, where there is no pain, but there is only weakness of the extensor muscle will be there. So in case of radial tunnel syndrome, there will be pain as well as weakness. But in case of posterior interosseous nerve entrapment or PIN syndrome, only there will be weakness of the extensor muscle. There will not be pain. So this is one of the differentiating clinical feature in case of radial tunnel syndrome and posterior interosseous nerve entrapment syndrome. Okay, now coming to bursitis, one of the most common bursa which is involved in the elbow is olecranon bursa, and as you can see in the picture here, you can see swelling, redness, and swelling at just over the behind the olecranon head, or just at the posterior part of the elbow. You can see a small bursa is naturally present just behind the head of the olecranon process. But if there is any trauma, or if there is any inflammation, or if there is an inflammatory arthropathy, this bursa can swell up like this in the lower part of the picture, and it can give rise to the pain as well as swelling in the posterior aspect of the elbow joint. Okay, and so this is known as olecranon bursitis. If you see the symptoms, there will be swelling around the elbow, especially in the posterior part of the elbow. There will be pain in the elbow, especially when the elbow is flexed and extended. Okay, and there can, because this is the bursitis, we can also appreciate increase in temperature and we can also appreciate redness around the posterior part of the elbow joint. So basically it is saying that there is a elbow bursitis or olecranon bursitis. And if you see the causes, it is mainly secondary to repeated motion of the elbow, especially like baseball player or the cricket player or the bowler of the cricket. Or sometimes, we tend to lean over the elbow joint for a long period of time, like I'm doing right now. So okay, I'm leaning over the elbow joint. So this is what we commonly do nowadays, and we usually play with mobile. So this is also one of the common cause of the olecranon bursitis, especially position or pressure over the elbow. Okay, so this can be another, or trauma or sudden blow on the posterior part of the elbow can also be the cause of olecranon bursitis. And in the olecranon bursitis, this is the typical picture of the bursa just behind the head of the olecranon, below the skin, between the skin and the olecranon process or head of the olecranon. You can see the bursa. Here you can see multi-septated bursa, and you can also see thickening of the bursal wall. And if you put a color Doppler here, you may also find lighting up of the color Doppler here, okay, especially around this wall surrounding this bursa. So this is the typical picture of the patient with olecranon bursitis, and you can see the position of the patient. Okay, this is the position of the patient. You can see the position of the probe is using the linear probe, and you can also see the direction of the needle. Okay, and this needle is on the right side. You can see the entire length of the needle going into the olecranon bursa. And normally in these conditions, we either, if it's a large bursa, we can aspirate a small amount of fluid and we can inject local anesthetic with steroid into the bursa to take care of the pain and inflammation. So these are the typical picture of the olecranon bursa, and this is the picture how the intervention is done. Long axis view along the ulna in the posterior side, and you can see the in-plane needling. Okay, and you can also see the entire length of the needle in in-plane needling going into the olecranon bursa, and we are doing the aspiration of this bursa and injection of small amount of steroid into the bursa to take care of pain. And another is like tendon, like there can be tendinosis or complete tear of biceps tendon. And you can see, so this is the complete tear of biceps tendon. Actually, this is the hypoechoic structure is the biceps tendon, which should be attaching to the radial tubercle. Okay, radial tubercle, and it should be tense. But you can see this is laxed, and you can see discontinuation of ideally this biceps tendon will be tensed, and it should be straight and tensed, and it should be attaching to this radial tubercle of the radius bone. But here you can see wavy biceps tendon, and the distal end is lost. We are not being able to find out the distal end. That means at the site of attachment there is complete biceps tendon rupture. You can see because this is wavy, because the proximal part of the biceps tendon is retracted. Otherwise it had been, if it was intact, it would have been a straight biceps tendon getting attached. This is radial tubercle of the radius. Okay, and you can also appreciate hematoma, hypoechoic hematoma over the site of attachment of the biceps. So as sir, as you have nicely said, for to check the integrity of the biceps tendon, especially at the site of attachment, the anterior approach is better. But if you want to do any injection into the biceps tendon, then the posterior approach or cobra approach is better. So supination and pronation of the flexed elbow, you can easily see the distal attachment side of the biceps tendon coming in and out once we do pronation and supination of the hand. So to check the integrity, anterior approach is better. And for the needling or to inject PRP or dextrose into the tendon, posterior approach is better. So you can see here also, you can see I'm just showing, this is the picture of my friend Milton who was doing this procedure. Okay, so this procedure is not done by me, but he has beautifully injected this PRP. You can see if the tendon is intact, it will be straight like this. See the difference between the integrity. Here you can see this is the intact tendon, but you can see this is hypoechoic. So this is tendinosis of biceps tendon, not tear, not complete tear. Okay, tendinosis. As you can see, this is the straight tense biceps tendon is there. And Dr. Milton is injecting from anterior approach. You can see the needle coming here from anteriorly, and it is just piercing the distal part of the at the site of attachment of biceps. And you can see nice this tense biceps tendon at the site of attachment. And my friend Milton is giving PRP at the site of tendinosis of biceps tendon from the anterior approach. You can see the needle is piercing the distal part of the tendinosis part, because this is hypoechoic, and but the integrity is intact because it is tense. If you compare with this previous picture, okay, just compare with the previous picture. Here you can see this is not tense, it is wavy, like a wave, okay, of the ocean. It is not tense, it is wavy. That means at the site of distal end it is ruptured, and everything, the tendon is retracted, and the distal end there is hematoma. But if the tendon is intact, you can see nice stretched tendon getting attached to this radius. And you can see Dr. Milton is giving PRP injection in the tendinosis part of the biceps. But you can also injection is best done in this cobra position or posterior position. So as nicely demonstrated, supination. In supination, okay, in supination tendon will be, you can see here, in supination tendon will not be seen. Tendon will not be seen. But if the hand is pronated, you can see a bird beak like tendon coming. This is the distal end of the biceps getting attached to the radial tubercle of the radius. You can see nice bird beak like appearance coming between the ulna and radius, and it is attaching over the radial tuberosity. So when this is done, hand is done, supination. And when a pronation, so when the hand is done supination, you can see there is no tendon between the radius and ulna. So here you can see there is only, you can see radius and ulna. But if the hand is done like cobra position like this is called cobra position. Okay, here you can see the biceps tendon coming and getting attached. So this is the very nice way of injecting into the biceps tendon. Here you can see the red line is the trajectory of needle, and you can go and inject into this tendinosis part or a partial tear part of the distal end of the biceps. Okay, so these are the two commonly done procedure to go into the biceps tendon and go for the injection in the biceps tendon. Okay, so thank you very much. This is a small reminder for you all. So these are our very lovely and renowned faculty from home and abroad. So all these eminent speakers are coming to our ICRA pain for their lecture. I would request everybody to join ICRA pain and have a good time with all the faculty member and with us. Thank you very much. Thank you, sir, for the.
So thank you very much. Thank you very much, Series, for your excellent presentation and very nice videos. And I'm sure everybody has enjoyed your, elaborate description. So thank you very much.
Thank you, sir.
So all the fellows are becoming fan of your presentation. I'm sure I'm getting very good comments about your teaching.
So thank you, sir. It is all because of you, sir.
No, it's okay. It's your dedication. So thank you all. I hope if you are having one or two quick questions, you can ask us before we are saying good night for today. Any quick questions?
So can I ask a question, sir?
Yes.
So this radial tunnel syndrome, it is the entrapment of the deep branch of the radial nerve only, or it's before it splits into the two nerves?
What?
Superficial.
It is a deep branch
So
only. Superficial branch is it already divided. It is the deep branch which is entering, and what Series has very nicely told that when it is entrapped, when it is entering, then we call it as a radial tunnel syndrome. But if the nerve is entrapped beyond that, then we call it as the posterior PIN syndrome, posterior interosseous nerve entrapment syndrome. And Series has very nicely explained that there will be pain as well as weakness if it is the radial tunnel syndrome, and this tenderness will be little below 2 finger below the lateral epicondyle, and it is very commonly mistaken as a the tennis elbow because both is causing the lateral pain. The difference here, the tenderness will be approximately 2 finger below the lateral epicondyle, so over the supinator muscle. So that is how to differentiate, but it is the deep branch only. Okay.
Yes, sir. And we do hydrodissection exactly where we see the entrapment, sir. Where the
Right,
same
right.
point.
Normally,
We,
if you are giving dextrose, no, if you are giving 5% dextrose, you can give a little larger volume because 5% dextrose don't have any upper limit. So what is important that if you are giving the 5% dextrose, it will go run little proximally, little distally also. And
okay.
what is the end point? Till you'll be seeing the nerve is floating nicely in the the dextrose, that is the end point. If you are giving steroid, then you cannot give a large volume. Then 1 to 2 ml is the your volume, around 2 ml is the volume if you are giving steroid. Both are having the evidence based recommendation, but nowadays for the nerve entrapment syndrome, any nerve entrapment syndrome, 5% dextrose is having the better evidences over the steroid. But steroid is
And
a
sir,
old
how
one,
often?
old is gold, so that also you can go ahead.
So how often we can repeat this, sir? We should repeat it, or we repeat
You
only if
see,
the
if you are
patient
giving,
has
if you are
complaints
giving,
again.
if you are giving steroid, then you cannot repeat too often. Then one injection and second injection must have a gap of around 2 months. But if you are giving 5% dextrose, then there is no need of repetition most of the times. And even if you are repeating, there is no harm.
Okay, sir.
If you are
Thank
doing
you,
the
sir.
hydrodesis nicely, most of the times, there is no need of repetitions. Okay, any more questions from anybody?
Sir, I have one question.
Yes, yes, yes.
Sir, for golfer's elbow and tennis elbow, when do we start the physiotherapy?
Normally after the few days, not immediately. So after the few days.
Okay, sir.
This
And
is
if
this
we are
is
given
this is not just for the tennis elbow, golfer's elbow. This is true for any of the intervention. Whenever you're doing, don't start the physiotherapy immediately. Give few days after the injection sore is basically subsided, and after that you try maybe 3 to 7 days. After that you can gradual physiotherapy. This is true for not just for here, everywhere, everywhere. Don't start physical therapy exercise program immediately.
okay, sir.
So can I ask a question, sir?
Yes, yes.
So for PRP, do you practice leukocyte rich or leukocyte poor PRP for different structure? So like for tendon versus osteoarthritis joint.
You see, earlier this leukocyte pure, leukocyte reach, this was having the lot of the controversies, recommendations, but almost all the recent studies are telling the leukocyte poor and leukocyte reach do not make much difference. So that's why, because if you want to make a leukocyte poor, then you have to make a double spin. Then only you will be making the. If you are doing a single spin, then it will be leukocyte reach. So leukocyte reach and leukocyte poor does not make any difference. So nowadays the recent recommendations, earlier all those was there. Earlier what was done is your tendinosis and all those things. Leukocyte poor was given. But that doesn't make no difference whether you are giving leukocyte pure or leukocyte rich. Results are similar.
So from your experience, we use leukocyte rich, just single spin.
Yes, single spin, single spin.
So for tendino
We do leukocyte reach on.
for tendinosis, both and also for osteoarthritis joint.
Right, right, right.
Oh,
Joint
thank you,
also
sir.
as well as tendons. Same.
Thank you, sir.
So can we use dextrose for these epicondylitis, sir?
Actually, in the don't tell epicondylitis. Epicondylitis
Yes,
is a basically wrong tendinosis.
epicondylis
It's a
yes.
tendinosis of the common flexor or common. So the dextrose also the most important part that you should be doing the multiple fenestration. That is the therapeutic one. And you after that you can give dextrose also. Some papers are there in favor of dextrose also. But if you are telling What is having the evidence-based recommended, the recommendation? PRP is the evidence-based recommendation is there. But dextrose also have good amount of the evidence. Many people give dextrose, and dextrose is also known as, first day the series told dextrose is known as poor people's PRP. Okay.
So if there's no evidence of inflammation, so you don't recommend any steroid for lateral epiculagia or media?
Earlier, the steroid only given. No, I have given so many steroid injection early. So still now, many people give steroid injection. But only concern about the steroid injection is that steroid must not be injected within the tendon. Then there is a possibility of tendon rupture. So, but if we are analyzing all the current evidences, PRP having the maximum evidence. But steroid or dextrose, these also can be given.
Thank you, sir.
Okay. So good night for today. Right?
Good night.
Yes, and again,
Good night.
join
Thank you.
iCrapen. Our series has already told our, the all the Daradia fellows we meet in person here in the online platform we are talking, but it will be great if we are meeting in person. So please join iCrapen. Only 1 month and few weeks. So thank you very much and good night for today.
Good night, sir.
Good night. Good night.